Okay. Hello, good evening, people. Good evening, guys. Good evening. Hello, all you wonderful people. Thank you for joining in live. Um, Hi, good evening, everyone. I cannot respond individually to everyone, so good evening, everyone, guys, and welcome to the session. I know the time is crucial. It's a very important time. We have 1 week left for the exam, so I'll make sure that I'll not waste any time of yours. I will not talk anything in between. So it's just about the academic discussion and about the INI questions of the previous year. I'll try to go a little fast because these videos are available with you. You can always watch them again whenever you want. I mean, till your INI CET exam at least, and you can always increase and decrease the speed. So I think that is all in your hand. Uh, okay. I do not want to answer any question right now because once we are done with the session, then obviously I can take up some queries and doubts because the people who want to leave after that they can, and they can continue with their work. So guys, without a further ado, let's start with the questions here. And I'll be discussing around 48 to 50 questions with you in this. And again, the point is that it's not about the previous year question that we have to discuss. We also need to see that what new can be asked from those questions and how to deal with that here, right? So not going into too much of detail of any questions here, fetching the right answer, knowing what the options are incorrect here, and also to see that what are the arbitrating questions from there, what are the questions which can be asked from the same topics again. Chalo. Okay, let's get started. And yes, don't worry about the PDF and all. You will find the PDF immediately after my session. Within 5 minutes only, it will be posted in my Telegram group. It will be posted in all the Telegram groups I am in, and also in the DBMCI Premier group as well. So don't worry about that slide. So just sit back, relax, and listen to this discussion here. So here we go, guys. Let's start with the question number 1. Well, as I said, I've arranged these questions based on the topic, so I'll go with the head and neck, neuro, embryology. That's the way I've arranged these questions here, and they're all previous year questions of INI CET specifically. Well, it says, which of the following foramen is located between the 3 bones? It was a question asked a couple of years back only. Now, there are 4 foramen which are marked over there. As you can see, this A here is a foramen ovale that is present in the greater wing of sphenoid. The foramen B, that is actually called as foramen lacerum, and that's actually the answer to our question, which is present in between the multiple bones. Then we have foramen C. Anyone can identify that. That is foramen magnum. And foramen D here, it's another important foramen, that is the jugular foramen. Well, the answer obviously is option B. Yes, foramen lacerum here. Now let's have a quick look at the jugular foramen. Now guys, jugular foramen, this foramen lacerum, not jugular foramen, sorry. The foramen lacerum, it is actually situated between the 3 bones. Now what are the 3 bones here? Now look at my this pointer here. This here is a petrous part of temporal bone. If you see more toward this side, that's a greater wing of sphenoid. Here we have body of sphenoid here, that's a body of sphenoid, and that's a basi-occiput, the occipital bone, the basilar part of the occipital bone here. So the 3 bones surrounding it, we have a sphenoid bone, obviously greater wing of sphenoid as well as body of sphenoid. We got the apex of the petrous temporal bone and the basilar part of the occipital bone also. Sphenoid bone ke dono part cover kar rahe hain, isko body bhi aur greater wing bhi. So that's the foramen which is present between the 3 bones. So developmentally, this is not a foramen present inside any bone. It's a kind of space left between the bone, and that's foramen lacerum. Okay. Moving on to question number 2. The question number 2 says, which of the following structure passing through the jugular foramen has a separate passage? Now the question was about the content of the jugular foramen only, but still having a separate passage here. So let me again just point out the jugular foramen to you. So there's a jugular foramen present in the posterior cranial fossa. Very important foramen, guys. I mean, this question is on the jugular foramen is asked from the structure point of view. Sometime a clinical question also, which I'll have one of the question for you here. Now, the jugular foramen is basically giving passage to what? Now let's say this is just architecture of a jugular foramen. It is giving passage to the 2 sinuses, that is inferior petrosal sinus and the sigmoid sinus, the 2 sinus which together will give rise to the internal jugular vein just below the jugular foramen. It also gives passage to the 9th, 10th and 11th nerve. The 9th, 10th and 11th nerves are also coming out of it here. And it is also giving passage to some meningeal branches, the branches of ascending pharyngeal artery and occipital artery, which are supplying the dura mater. So some meningeal branches are also coming out of it. Now that one thing is that they could ask you the question about the arrangement of the structure. That is one thing here. Also, remember 9th and 10th nerve and 11th nerve, the 3 nerves, out of these 3 nerves, see, anyways, hypoglossal is out of the picture. Hypoglossal is present in the hypoglossal canal. The question is about the jugular foramen, the content of jugular foramen, but still having a separate passage. 11th and 12th nerve, they together forms the vago accessory complex, we know that, and that's why they run in the same dural sheath. So we have a common dural sheath for the 10th and 11th nerve, and we have a separate dural sheath for the 11th nerve, 9th nerve, I'm sorry, and that's why glossopharyngeal nerve is the answer to this question. So 9th nerve is a structure of jugular foramen, but it is having a separate passage because it is having its own dural sheath. 11th and 10th and 11th nerve, they will join together to form the vago accessory complex. So that's the answer to this question here. But remember, jugular foramen is an important question here. It could be about the foramen, it could be about the structures passing through it, it could be about the fracture, which is like extending to the jugular foramen, and what could be the features here. I have one question coming up for that. Okay, now moving on to next question here. That's another question asked in the INI exam that was about the third part of the vertebral artery is related to which of the following here. Now in this question, the catch is a third part of vertebral artery. Vertebral artery, the moment you think about the vertebral artery, the main thing that comes into our mind regarding the cervical vertebrae is the foramen transversarum. So foramen transversarum will give passage to the vertebral artery, but actually it's not the third part, it is the second part of vertebral artery which passes through the foramen transversarum. Now, have a quick discussion on this vertebral artery, guys. We all know that vertebral artery is a branch of subclavian artery. So let's say in this picture, that is a subclavian artery. That's the first part of subclavian artery, right? And starting from the first part of subclavian artery, look at that. That's the vertebral artery. So from here, from the beginning till the foramen transversarum, till the time it reaches the foramen transversarum of C7 or sometimes C6, that portion is called as a first part here. That's the first part of vertebral. The portion which is running within the foramen transversarum here, till C1, that is the second part of vertebral artery. Then from the foramen transversarum of C1 vertebrae, it makes an arch, it basically runs on the posterior arch of the atlas and then enters the foramen magnum, and that small part which is present in the suboccipital triangle also is called as the third part, and the fourth part is the intracranial part when it goes inside the cranial cavity and forms the basilar artery also, that is the fourth part. So again, coming to the point, the question was about the third part of vertebral artery. Had it been the second part of vertebral artery, then obviously the answer would have been option C. But because there is a third part of vertebral artery which comes out and then runs on the posterior arch of atlas and then enters into the foramen magnum. So this is the posterior arch of the atlas. You can see the larger arch here. First of all, I'm pretty sure that nobody is having a problem in identifying the first cervical vertebrae. There is no body in it. We only have anterior arch and posterior arch. Anterior arch is smaller, posterior arch is larger. And then this is the posterior arch which is also having this groove. Can you see a shallow groove there? There's a groove for the passage of third part of vertebral artery, and even the first cervical nerve, the C1 nerve, will also come out of it. And that's why for this question answer is D, that is the posterior arch of atlas, the posterior arch of atlas. Moving on, next question here. Which of the following is or are true regarding the marked area in the given image? Now this question is again a repeat question, guys. This question is asked twice in the INICET, once in the NEET exam, so it is an important question here. I'm pretty sure everyone knows that there is a junction of the four bones at this point which is called as a pterion. Now marked area is pterion. It is formed by so and so bones, whatever it is written, I'll come to that here. Side blow to the skull can lead to the fracture of this region. Yes, it is a very thin part of the skull bone on the side here. Falling on the side or any blow on the side of the skull can lead to the fracture of this region. And accessory meningeal artery lies deep to it. So we need to assess that which statement are true and which statement are false here. Let's have a quick discussion on this foramen here. Suture here. So this H-shaped suture that you're looking at here, which is pointed by this circle here, it is first of all, it's a junction of the four bones. Now, which four bones are meeting there, guys? First of all, we have a parietal bone. You can see the parietal bone is contributing to it. We have a contribution from the frontal bone, We do have a contribution from the squamous part of temporal bone, and we also have the contribution from the greater wing of the sphenoid. So again, this could be a question here, that what are the bones which are contributing to this pterion here? So these are the four bones which are meeting together, and that suture here is called as a pterion here. Well, the immediate deep structure to the pterion here is a middle meningeal artery, anterior division of middle meningeal artery. Now, once again, if I just kind of show it a little shadow of the brain on this skull bone here. So that is the area where the pterion is present. Now, what are the relations of the pterion, guys? What structures are lying deep to it here? So obviously, the middle meningeal artery enters through the foramen spinosum, and the anterior division, or so-called the frontal division of middle meningeal artery, is related to it here. And that's the one which is commonly involved in the extradural hemorrhage also. If there is a fracture of the pterion region here, there will be rupture of this artery and can lead to the extradural hemorrhage. So in the relations, we have this anterior division of middle meningeal artery, middle meningeal vessels, we should say. Then we also have, now if you look at this, that's a Sylvian point here. The Sylvian point from where the lateral sulcus is coming out and dividing into this ascending limb, anterior limb, and then we have the posterior limb also. So that Sylvian point is here. If you open the lateral sulcus is there. You can see that shadow of the lateral sulcus. If you open the lateral sulcus, then obviously insula is there. The hidden lobe of the cerebrum is also present over there. And if it is like for right-handed person, the dominant cortex is the left side. So even the Broca's area lies close to that. You know, the Broca's area number 44 and 45, that is also present very close to this between this ascending limb, anterior limb, and the posterior limb of the Sylvian sulcus. So all these structures are lying deep to the pterion here. So it's anterior division of middle meningeal artery, which obviously is the best answer because that is immediate relation deep to the pterion. But if you go further deep inside, then you'll find the middle cerebral vessels also, you'll find the Sylvian fissure also, you'll find the insula, the hidden lobe, that insula, the entry point to the insula is there, and even the Broca's area. On the left side, in the left cerebrum, you also have the Broca's speech area, or the motor speech area is also located deep to it. So that's about the pterion part. So remember that they already asked this question more than once here. So you should know that what bones are forming it, and you should also know like probably all the structures which are lying deep to it, not only the middle meningeal artery. Chaliye, moving on. The next question. Well, now so first of all, let's get the answer to that question here. So out of these options which were given over there, the marked area is pterion, that is correct here. Second is not correct because they have mentioned the maxilla bone, which is not contributing to it. Third is correct, yes, the side blow can lead to the fracture. And fourth is incorrect, that is accessory meningeal artery. It's the middle meningeal artery which is lying deep to it. So it's 1 and 3 which are the right answer. Okay. Now, the next question here, that is a question from the base of the skull here. And the question says a patient with a fracture of the base of the skull extended to the marked foramen will be presenting with which of the following symptoms? Now, first of all, let me tell you one thing, guys. See, there could be a little variation in the kind of questions which you find it in the different apps or different books here. It doesn't matter. As long as we know that what topic is being asked, that is good enough for us. You need to like read around that topic. That's the most important thing here. Because during recall, things get changed, like some options, some questions. So the way the question was presented will change here. And I'm pretty sure you people are smart enough to like, if you find out that what topic is being asked, you can always get the answer to the questions related to the same topic here. Now, this foramen here, that's another view of the jugular foramen. And this time we are showing the jugular foramen from the base of the skull. So the fracture of the base of the skull, the jugular foramen can get involved in that case here. And jugular foramen, you already know, is giving passage to the 2 sinuses and 3 important cranial nerves, that is 9th, 10th, and 11th nerve. Now, we have to find out that what exactly will happen because of that. Option A says loss of general sensation of anterior 2/3 of tongue. No. General sensation kab hoga? Loss of general sensation when the lingual nerve is involved. And lingual nerve is a branch of mandibular nerve. वो तो foramen ovale के अंदर है. Then, loss of taste sensation over anterior 2/3 of tongue. Again, not possible. That is because of chorda tympani. Chorda tympani is a branch of facial nerve, and facial nerve goes into internal acoustic meatus. Cannot be the answer. Loss of taste sensation over posterior 1/3 of tongue. Yes. Glossopharyngeal nerve is one of the content of the jugular foramen, and that is responsible for carrying the general as well as taste sensation from the posterior 1/3 of tongue. So, of course, 9th, 10th और 11th nerve के features मिलेंगे आपको. That's why the loss of taste sensation, loss of general sensation, bulbar paralysis, loss of gag reflex, all that will be there if the fracture will involve the jugular foramen, and the structure present in them will get affected here. Motor function of the tongue will lost. Well, motor function of the tongue will be lost only if the hypoglossal canal is involved, and hypoglossal canal is close by only. Hypoglossal canal is in front of these condyles only, but the pointer is not on the hypoglossal canal. That can't even be seen here actually. We are looking at the jugular foramen there, and that's why the answer is option C. 9th nerve, that is coming through jugular foramen, and yes, that is the one which is responsible for carrying the sensation from the posterior 1/3 of tongue. Also understand one thing, there are certain nerves which are being asked over and over again in a different format here, like the injury to the question about the deviation of the uvula. There was a question asked on that. Loss of gag reflex, that is again the 9th and 10th nerve. The question about the fracture of the base of the skull extending to the jugular foramen. So these are the same topics being asked over and over again, but the different ways में पूछ रहे हैं. कभी osteology point of view से they ask these questions. Sometimes they give a clinical scenario, but it's pretty simple. If you know the foramen, if you know what structure is passing through that, it's a very simple, even by the simple method of elimination also you can reach the right answer. चलिए guys, Another question here, identify the marked foramen in this butterfly shaped bone here. Well, only INICET is one exam which usually gives these individual skull bone questions here. Otherwise, I don't think कि दूसरे exams के अंदर आते हैं. So generally, this INICET you can expect a question like maybe a question on the temporal bone or maybe a question on this sphenoid bone. This is one of the INI question only. Now, first important thing in this is, I'm pretty sure everyone know that's a sphenoid bone here. Now, what view of sphenoid is this? Now guys, this is the anterior view of the sphenoid bone. Agar ye posterior view hota, if this would have been a posterior view here, then I would be looking at this fossa where the greater wing of sphenoid can also be seen. So I would see the foramen ovale and foramen spinosum would be visible, jo nahi dikh rahe mujhe. Moreover, look at that lesser wing of sphenoid there, that is facing toward the posterior side. That's a greater wing of sphenoid here. Lesser wing of sphenoid is projecting toward the middle cranial fossa, and they form a process called as an anterior clinoid process. And I cannot see them. They are toward the posterior side here. So that's an anterior view of the sphenoid bone, first of all. Now the two foramen there, which you can appreciate apart from the superior orbital fissure, I can see the foramen which is marked as A here, that is the foramen rotundum. And I'm sure everyone knows that foramen rotundum gives passage to the maxillary nerve. And just below the foramen rotundum, inferior medial to foramen rotundum, आपको एक और छोटा सा foramen दिख रहा है यहाँ पे, the canal there. And this canal is basically traversing from the anterior wall of foramen lacerum and then opening into the pterygopalatine fossa. It opens into the pterygopalatine fossa. That's the area of the pterygopalatine fossa, and the nerve will come into it. And this is the pterygoid canal or Vidian's canal, which will give passage to the greater petrosal nerve, deep petrosal nerve, and even the artery to pterygoid canal will go through it here. So when you see this sphenoid bone from the front here, do expect to see these two foramen. One is a foramen rotundum and foramen the pterygoid canal or Vidian's canal here. बस ऐसा समझ लो, जो ऊपर है that is a rotundum here, the one which is like below that is the Vidian's canal or pterygoid canal. But I'll answer your questions. Let me just finish off this portion first. Okay, so foramen rotundum is the answer to this question here. Okay. Moving on, the next question. See, it becomes a little challenging when you look at the cranial fossa with the durameter intact on it. Because now no foramen is visible here, and you still may have to identify the nerves on it here. Now this was a question asked in which they said all of the following nerves are associated with the ocular movement, the eyeball movement, except which one? Which nerve is not responsible for the eyeball movement here? Now again, the thing is that look at these projections here. Look at this tapering pointing projections over there. Now that is the anterior clinoid process here. That's a part of lesser wing of sphenoid. And the moment you look at the anterior clinoid process, the medial to the anterior clinoid process, we have the optic canal here. So that's a landmark here. I cannot see the foramen there, but I can at least make out these projections, these triangular projections over there, which is the anterior clinoid process. And medial to the anterior clinoid process, we have optic canal. And if it is optic canal, so obviously optic nerve and ophthalmic artery will go through it here. So A obviously is an optic nerve here. And in fact, that's the answer to the question in fact also. Now, then we have the nerves arranged like this, which are forming the lateral relation of cavernous sinus. Abhi cavernous sinus यहाँ पर कहीं होगा ना? Pituitary gland is there. Just lateral to pituitary gland, we have a cavernous sinus here. So the nerves which is present in the lateral wall of cavernous sinus are aligned like this here. So we got a third nerve, we got a fourth nerve, and look at that, the one which is not marked here, that is the trigeminal nerve. We know the ophthalmic and maxillary part of trigeminal nerve are also present toward the lateral side of cavernous sinus. So all these nerves, जो आपको एक line में दिख रही है, the one that you see aligned here, these are the nerves which are present in the lateral wall of cavernous sinus. The third and fourth are marked in it here. And the one nerve, the only nerve that you see on the clivus here, the only nerve that you will see on this slope, that clivus, on the posterior cranial fossa, this slope is called as the clivus where the brainstem is present. And that nerve, the nerve which is having the longest intradural course, the nerve which goes inside the cavernous sinus, and that is abducen nerve. They have also asked this question about the identification of the abducen nerve, which I very strongly feel is a question which can be repeated because abducen nerve confusing लगता है, because that is the nerve present somewhere here. Rest of the nerves for the eyeball movement and all, they are present very much on the outer side here. But the one nerve that you see on the clivus entering into the durameter there itself here, having a longest intradural course, having a course inside the cavernous sinus also, यहाँ से cavernous sinus के अंदर जाएगा ये, that is the abducent nerve. So guys, these are the four nerves that you're looking at: optic, oculomotor, trochlear, and abducen. And of course, the answer is optic nerve. That is for the vision and not for the ocular movement. Moving on. Okay, true about trigeminal nerve. Now, this is a question last year, INI question only here, that what statement is true about the trigeminal nerve. Now, let me just put a picture here and just tell you quickly about the main features of the trigeminal nerve. Now, have a look at this image, guys. And do not look at the too many labelings in here. I have highlighted the important areas for you. See, there is a trunk of the mandibular nerve, first of all. See, the question is true about the trigeminal nerve, but when you look at the options here, all the options are actually about the mandibular nerve only here. So the trunk of the mandibular nerve, it supplies one muscle of mastication, and that is medial pterygoid. Now that's very important question. This question have been asked earlier also. It's one of the earlier old JIPMER question also, and that is that nerve supplying the medial pterygoid muscle, that is the coming from the trunk. The only muscle of mastication supplied by the trunk. Moreover, the same nerve which is supplying medial pterygoid, it is also supplying the two tensor muscles, tensor veli palatini and tensor tympani. So the two muscles with the name tensor are also supplied by the same nerve which is supplying the medial pterygoid here. So that is about the trunk. When you look at the division here, remember that anterior division is mainly motor. Anterior division का काम है muscle को supply करना. It supplies muscles of mastication, lateral pterygoid, medial pterygoid, masseter, even buccinator, not buccinator, I'm sorry, a buccal nerve it gives off, which pierces the buccinator but doesn't supply it here. So from the anterior division, we have all the motor branches which are supplying the remaining muscle of mastication, but it also gives off a one sensory branch there, the only sensory branch, that is buccal nerve. This buccal nerve, it pierces buccinator, but it doesn't supply it here. That's a question also. This nerve pierces the buccinator, but it doesn't supply it. It's a sensory nerve supplying the skin of the cheek area, the mucosa, but not the muscle. So that's a sensory branch from the anterior division. Posterior division, three branches which I have highlighted with the green color over there. Those are called as Ali branches. I don't know if you are able to see them clearly in this here. You will definitely be able to see in the PDF image. So we have Ali branches. One is auriculotemporal, a very, very important nerve, guys. Auriculotemporal nerve, the nerve which supplies the upper 2/3 of auricle, temple. TMJ, it supplies the temporomandibular joint, and it is also the nerve which is carrying the secretomotor fibers to the parotid gland also. Auriculotemporal. The moment say you auriculotemporal, आपको यहाँ पे सोचना है. This auricle and temple. It supplies the auricle region, temple region, TMJ, and also supplies the parotid gland. Secretomotor fiber to parotid gland. Then we have another nerve that is called as the lingual nerve. Lingual nerve which is carrying the general sensation. Look at that. That's a lingual nerve here connecting to the submandibular ganglion, and that lingual nerve is carrying the general sensation from anterior 2/3 of the tongue here. और क्योंकि मुझे दिखाई दे रहा था, I should tell you here that lingual nerve is very closely related to the Wharton's duct also, guys. So any surgery of the Wharton's duct, the lingual nerve can get injured here because there is, like you can see, the lingual nerve is winding below this Wharton's duct. And then we have a nerve called as inferior alveolar nerve. The inferior alveolar nerve is the one which goes inside the mandible here, supplying all the alveoli, supply all the gums and teeth, comes out as mental nerve. So that is basically sensory for the alveoli here. But this inferior alveolar nerve, it also gives off a branch which supplies the mylohyoid and anterior belly of digastric also. So see, the crux is, when you look at the mandibular nerve obviously is for the muscle of mastication here. But mandibular nerve supplies couple of muscles which are not muscles of mastication, and this is where the examiner is more interested in asking questions from. Like tensor veli palatini and tensor tympani, mylohyoid and anterior belly of digastric. Tensor veli palatini, tensor tympani, mylohyoid and anterior belly of digastric. So remember, these are the muscles which are not muscles of mastication but supplied by mandibular nerve. So let's go through the options, guys. Auriculotemporal nerve is a branch from the anterior division of mandibular nerve. No, it's not. Auriculotemporal nerve पीछे से आ रहा है, posterior division से आ रहा है. Buccal is a branch of posterior division. No, buccal is the only sensory branch coming from the anterior division. Medial pterygoid is innervated by the trunk, and that's true. That's the only muscle of mastication which is supplied by the trunk here. And posterior division branches are sensory. That is also not true. Posterior division की सारी branches जो हैं, you can see they are all, most of these branches are mixed branches. They are having a sensory function also and motor function also, secretomotor, supplying the muscles as well. So I've always believed that trigeminal nerve is a very important nerve. I always say this in my class also, that trigeminal nerve आपको बहुत अच्छे से आना चाहिए ना. If you want to understand the other parasympathetic nerve, you need to have a good hold on the trigeminal nerve. So I kind of, I personally feel very strongly for this trigeminal nerve again to be asked in the upcoming exam also. So keep an eye on this one. Okay. Moving to the next one, guys. The next question says the patient having a paradoxical respiration, which of the following nerve will be affected? Well, again, this question is asked twice in two different formats here. One, they kind of converted this question into a clinical one. And once they asked this question simply about identification of the phrenic nerve. Now, we know the paradoxical breathing they are talking about here. The diaphragm obviously is the answer, and phrenic nerve is supplying it here. The question is, where is phrenic nerve and how do you identify the phrenic nerve? Well, first of all, guys, look at this muscle which I'm pointing at right now. This muscle is a scalenus anterior muscle, and the scalenus anterior muscle is inserted to the first rib. It goes and attaches to the first rib. There is a tubercle on the first rib where it attaches here. And it's very important to know the relations of the scalenus anterior. You know, there are certain muscles for which the relations are asked, और randomly ऐसे कोई relation नहीं पूछता, ऐसा नहीं कि they will just pick up any muscle XYZ from the body and they'll ask you the relation. They have some clinical correlation is there here. You can see some important structures are present in front of it here. So, subclavian vein is there. For the central line, you need to know that what is the relation of the subclavian vein, the structures close by to the subclavian vein. So that's the reason that the relation of these muscles are important, and they have been asked in two different ways. Like once they asked which one is the phrenic nerve, and one this was a question. Both the time it was an INICET question only. Well, phrenic nerve, we have to identify phrenic nerve here. Now, first of all, look at this. If you're not able to identify the phrenic nerve directly, let's go in a passive way. I can see the carotid vessels there. I can see the carotid sheath structures there. You can see common carotid artery, internal jugular vein is there. If you can find out the carotid sheath structures, then obviously the nerve in between them is a vagus nerve. So vagus nerve, this B is a vagus nerve, of course, right? That's a vagus nerve. If this is a content of carotid sheath का posterior relation क्या होता है? What is behind carotid sheath? That is the sympathetic chain. Like ansa cervicalis is in front and sympathetic chain is behind. So sympathetic chain is behind. I can also see the ganglion over there. But even if that is not visible here, the sympathetic chain is present behind the carotid sheath. Again, present in front of scalenus anterior only. So that is the option C there is the sympathetic chain. I can see trachea there. I can see esophagus. Trachea, esophagus. Tracheo-esophageal groove. Now the nerve which is running back into the tracheo-esophageal groove supplying the larynx, that is the recurrent laryngeal nerve. So anyways, by the method of elimination also I can reach that the only nerve left here which is running in front of the scalenus anterior, that is the phrenic nerve. Now phrenic nerve, guys, it runs in front of the scalenus anterior, but remember this is a picture without the fascia. Deep cervical fascia is an important topic here again, and if once you put a fascia on this, all these nerves and vessels are present in different, they have a different relation altogether. Now think about it. Vagus nerve is inside the carotid sheath. Sympathetic chain is behind the carotid sheath. That means it is behind the carotid sheath, but in front of the prevertebral fascia. In front. Phrenic nerve is running in front of the scalenus anterior, but it is behind the prevertebral fascia. So in the transverse section, those fascias are the one which will help you identify these nerves. If I give you a transverse section, it's not easy to identify these nerves if you don't know the fascias of the neck here. So make sure go through that section, the transverse section of the neck, where the fascias are shown. I've discussed that in my one shot video also here. So, but yes, for this question, the answer is the phrenic nerve. Okay. Moving on to the next question. This question also was a last year question only, guys. The marked structure opens in which of the following? Now, you will realize something that sometimes we discuss all these big things here, but questions बहुत basic पूछते हैं. Like the questions could be as simple as identification of a certain muscle only. Like there are questions, and these are INICET questions I'm talking about here. There definitely have been the clinical questions also. Image-based clinical questions, image-based clinical embryology questions even have been asked here. But at times the questions are pretty simple and they are just about that whether you know that structure here and you just know the basics, that where it is opening, where it is present, where it is coming from, where is it going. Like the marked structure, I'm pretty sure everyone can identify that is a sphenoidal air sinus, right? That's a sphenoidal air sinus, and these are the nasal concha you're looking at. So there are three nasal concha we know, and deep to these nasal concha we have the three nasal meatus. We have a superior meatus, middle meatus, inferior meatus. But this sphenoidal air sinus, it opens into a recess in front here that is called as a sphenoethmoidal recess, guys. That opens into a sphenoethmoidal recess. But let me give you a quick look at all the openings which are present in the nasal concha here. If you remove all these nasal concha, तो सारे meatus आपको expose हो जाएंगे. All the meatus will be seen there. Now have a look at this schematic representation of that. Now let's start with this one here. That was the answer to our question here. That sphenoidal air sinus was marked and it is opening into this recess here. That is a sphenoethmoidal recess. That's a sphenoethmoidal recess. That's a superior concha. So that's a superior meatus. Now in the superior meatus we have an opening for the posterior ethmoidal air sinus. और नीचे आते हैं. That is a middle concha. Below middle concha, that is middle meatus. In the middle meatus, we have a bulla, ethmoidal bulla or bulla ethmoidalis. And on the bulla, we have the opening for the middle ethmoidal air sinus. And then we have this hiatus semilunaris here. Below the bulla, you'll see the hiatus semilunaris, in which anteriorly, now when I say anteriorly obviously you can think of what? Frontal air sinus. So it's an opening for the frontal air sinus below. Posteriorly, there is a maxillary sinus. And then in between, we have an opening for anterior ethmoidal air sinus. इसको थोड़ा अलग तरीके से देखते हैं. देखो, ethmoidal air sinus are the one which are a little confusing here. Now, what I would recommend you is that go with the ethmoidal air sinus like in this direction here. Now, when you see this one here, it is an anterior ethmoidal sinus in the hiatus. On the bulla, it is middle, and in the superior meatus, it is posterior. Anterior, middle, posterior. Anterior, middle, posterior. So go like this here from below upward. So that's the opening for the anterior ethmoidal sinus. On the bulla, it is middle, and then we have the posterior ethmoidal air sinus, which is opening in the superior meatus here. Inferior meatus में बेटा कोई वो open होता है नहीं. Inferior meatus is not for the opening for any of these, what do you say, sinuses. It is for the nasolacrimal duct. The nasolacrimal duct opens into the inferior meatus. So yes, the supreme meatus or the sphenoethmoidal recess, that was the answer to this question. Okay, now look at this, another question of the INI CET exam, and yet it's yet another example that they many a times they will test you just for the identification, ki whether or not you're able to identify the structure on the cadaveric picture especially. So again, the picture that I showed you for the sphenoidal layer sinus, that was also a cadaveric image here. This is again a cadaveric image here, because we sometimes we draw the line diagrams, we see the atlas images and all. Sometimes though we are not able to correlate them with the actual cadaveric images here. Now this is a laryngeal skeleton which is shown here, but obviously it is all covered with the membranes and mucosa, so I cannot see any cartilage or bone clearly here. But you need to have an idea about that, guys, what bone and cartilage are present in this. So let me put a comparative picture here so it will become easy for you. Have a look at this. Now, that over there is a hyoid bone, right? You can see epiglottis here. Obviously, epiglottis is connected to the hyoid bone. That is by a ligament also called as a hyoepiglottic ligament. Then this is obviously C is epiglottis. You can compare it here. That's the epiglottis here. That B over there, that's the section through the thyroid cartilage, right? That's a thyroid cartilage. Look at this. That's a thyroid cartilage there. And that D, that cartilage over there is this arytenoid cartilage. Look at that. That's a arytenoid cartilage here. If I see further below the D over there, that over there is a cricoid cartilage. This is what it is resting on. So that's a cricoid. Resting on the cricoid is arytenoid. There we have the thyroid cartilage. This is epiglottis. And answer obviously is what? Hyoid bone, which is not forming the laryngeal skeleton. It's option A, that is not forming the laryngeal skeleton. Right, so simple picture, you just have to compare it with the schematic line diagram and you know that what is not the part of the laryngeal skeleton there. Chalo, moving on. Another question, the AIMS question only here. Now, there are two questions on this part here, that which of the following is not a branch of facial artery and which artery supplying the face is not a branch of facial artery. Now, let me answer that question first. That which artery supplying the face is not a branch of facial artery. So, yaad rakhna, there is an artery called as a transverse facial artery, guys. There is an artery called as a transverse facial artery that comes from superficial temporal. A superficial temporal artery gives off a transverse facial artery. So transverse facial artery obviously will supply face, but that is not the branch of facial artery. So artery supplying the face, which is not a branch of facial artery, transverse facial artery, one of them. In this question, which of the following is not a branch of the facial artery? Well, answer is the dorsal nasal artery here, but let's have a very quick recap of the facial artery and its branches here. So here we go. That's the side of the face you're looking at. Now, facial artery, it originates just above the greater cornua of the hyoid bone. And when you see the facial arteries having a tortuous course, the cervical part of facial artery, then we have facial part of facial artery, and the facial artery enters the face at the anterior-inferior angle of the masseter muscle. This is the point, anterior-inferior angle of masseter, where the facial artery is piercing the investing layer, and it is coming out here. Neck mein deep cervical fascia hai. Face is not having a deep fascia, so the point where it is piercing the fascia and coming out is the anterior-inferior angle of masseter. Now, the cervical part of facial artery, guys, the cervical portion of facial artery, it gives off 4 branches, and these can be remembered as STAG, S-T-A-G. S, submental, tonsillar, ascending palatine, pharyngeal nahi, ascending palatine, and glandular artery here. So these are the 4 branches of the facial artery in the neck. The STAG branches is submental, tonsillar, ascending palatine, glandular. Submental obviously supplying the submental lymph node, tonsillar artery obviously for the tonsil, ascending palatine artery is also for the tonsil and palate, and glandular artery is for the submandibular gland here. So these are all cervical branches, neck mein nikal gayi sab ye. Then once the facial artery reaches the face, it gives an artery leg to the lower lip, that is called as an inferior labial artery. We have a superior labial artery. We got a lateral nasal artery supplying the ala of the nose, and then the terminal branch here is called as a dorsal nasal artery. So these A, B, C, D, these are the 4 branches of facial artery on the face. That is inferior labial, as you can see, for the lower lip, upper lip, superior labial, lateral nasal for the ala of the nose, and we have a dorsal nasal artery here, dorsal nasal artery. Now, dorsal nasal artery is a terminal branch of facial artery, but it is not an end artery. It is not the end of the artery here. It is not an end artery. It do anastomose with, and it do anastomose with the artery called as a dorsal nasal artery, which is a branch of ophthalmic, and that is coming from internal carotid. Dorsal nasal artery. That was our answer also, guys, that dorsal nasal artery is not a branch of facial artery. Facial artery terminal branch anastomose with dorsal nasal artery, which is ultimately coming from ophthalmic, and that is from the internal carotid. And that's why The medial angle of the eye is a point of anastomosis between the internal carotid and the external carotid. Again, could be a good question here, क्योंकि वो question पूछ रहे हैं facial artery के आसपास से, so they might ask you this question also, that which two arteries forms the anastomosis between internal carotid and external carotid. So it's the angular artery here and the dorsal nasal artery, the angular and the dorsal nasal artery. Yes, so that's about a quick recap of the facial artery and its branches. Chaliye, moving on. The next question is about the inferior thyroid artery supplies which of the following. Now, when you look at the name, guys, when the name implies inferior thyroid artery, so it's an artery for the thyroid gland here. But it बहुत कुछ करती है, guys. First of all, inferior thyroid artery is a branch of a thyrocervical trunk, and that is coming from the first part of subclavian artery. I don't have to go into that, but I'm pretty sure you know that. Inferior thyroid artery. In fact, this was also one of the AIIMS question only, that inferior thyroid artery is a branch of which artery. And see, this is what you need to understand, that's how they basically, evolve their questions here. Imagine they have asked a question as simple as inferior thyroid artery is a branch of which artery? Thyrocervical trunk. That was the answer. And just a couple of years later, then they ask this question here, when they ask about the detail about the inferior thyroid artery, that what all it is supplying here. Well, even if you apply certain logics, now you still can get the answer to this question here. The area which is like not even close by is the thymus here. Thymus reaches into the anterior mediastinum here, and thymus is supplied by the internal thoracic artery. We have some mediastinal branches of internal thoracic or so-called internal mammary artery that supplies it. So answer is like 1, 2, and 3. 1, 2, and 3 is the answer, like all supplied by them. But because this question is asked, let me just give you a little insight of this inferior thyroid artery. Now, we generally say that inferior thyroid artery is a branch of a thyrocervical trunk. But see, I've taken this directly from the Gray's Anatomy. These are the points from the Gray's Anatomy here. That inferior thyroid artery gives these branches. Now, it gives off muscular branches, which is supplying the scalene muscle also, and even the inferior constrictor also. So, pharyngeal muscle को supply कर रहा है यहाँ पे. Just keep an eye on that कि क्या-क्या supply कर रहा है. It gives off spinal, ascending cervical artery, which gives off spinal branches. They are all branch of inferior thyroid artery. It gives off ascending cervical artery, which gives off spinal branches. They basically enter through the intervertebral foramen, and they do supply spinal cord also. So it's not wrong to say that inferior thyroid artery ki branches did supply the spinal cord as well. Then inferior laryngeal artery. We have two laryngeal arteries, superior laryngeal, inferior laryngeal. Superior laryngeal artery is a branch of superior thyroid. Inferior laryngeal artery is a branch of inferior thyroid. Straight and simple. So inferior laryngeal artery is a branch of inferior thyroid artery, and that does supply the laryngeal mucosa and the muscles also. And then it gives off the pharyngeal branch, which is obviously supplying the pharynx, and that's a main glandular artery also, guys. The same this pharyngeal branch gives off the ascending glandular artery, which supplies the thyroid gland, and it does supplies the parathyroid gland also. Inferior thyroid artery ka jo main course that is on the posterior border, and obviously running on the posterior border, so it's supplying the gland as well as the main thyroid gland as well as the parathyroid gland. So pharyngeal muscles and constrictors and giving off spinal branches, gives off laryngeal artery, glandular artery, supplying esophagus, esophageal branches, thyroid and parathyroid gland also. So all of they are supplied by the inferior thyroid artery. Just make sure when I send this PDF to you, just go through these branches here, because again they can formulate the question from these branches. Diksha, कुछ confused नहीं होना बेटा, कुछ confused नहीं होना. Thymus is present in the mediastinum, anterior mediastinum, and that is supplied by the artery in the mediastinum. Inferior thyroid artery यहाँ क्या करेगा आके? Now, sometimes you don't need the right answer to the question, you just have to apply certain logics only here. Inferior thyroid artery mediastinum में तो नहीं जाएगा ना, in the anterior mediastinum. Next question, which is the nerve arising from the marked place? Now, this is again a very commonly asked question here. The commonly asked question I'm saying because the section of the brainstem given and then asking you to identify the nerve on that, it is a very commonly asked question. Now, they may not give you the nerve coming out from there, and they will just show you the region that, and then you still have to identify that what nerve is coming out from there. Like guys, it's a ventral aspect of the brainstem, midbrain, pons, medulla oblongata. Midbrain, pons, medulla oblongata. Now, midbrain, these are the cerebral peduncles. If these are cerebral peduncles, that is interpeduncular fossa, and interpeduncular fossa will give passage to the interpeduncular fossa will give passage to the third nerve. So the nerve coming out from the interpeduncular fossa is third nerve. And peduncle ke piche se, from the dorsal aspect of the peduncle, the fourth nerve will come out here. So third nerve is a content of interpeduncular fossa, and fourth nerve will come out from here. Pons, huge area of the pons here, but the only nerve that you see coming out of the ventral aspect of pons, and that too very much toward the lateral side, from somewhere from here, that's the thickest cranial nerve, and that's the trigeminal nerve. pontomedullary junction, junction between the pons and medulla, pontomedullary junction here. So that is the 6th, 7th and 8th nerve will come out from there. As I said, even if you're not able to see the nerves, just look at these elevations, guys. You can see the pyramid there clearly. You can see olive there. So pyramid, the junction of the pyramid and pons, pontopyramidal junction. Pontopyramidal junction, 6th nerve will come out. So answer to this question is the 6th nerve only. That's the abducens nerve coming out from there. Ponto-olivary junction, 7th nerve, and more laterally you will have an 8th nerve here. So 6th, 7th and 8th, they are coming out from ponto-medullary junction. 6th is from ponto-pyramidal junction, this one. 7th is from ponto-olivary, and furthermore we have a 8th nerve. Then I can see olive, so that means there is a junction between the olive and pyramid also. Olivo-pyramidal junction. Olivo-pyramidal junction is giving passage to the hypoglossal nerve. अगर आपको इस sulcus में से nerve निकल के दिखाई देगी बाहर आते हुए, that nerve is a hypoglossal nerve, the 12th nerve, the only nerve coming out between the pyramid and the pons, pyramid and the olive, I'm sorry. And the nerve that you see coming out like posterior to olive or more lateral to the olive here, those are the 9th, 10th and 11th nerve. 9th, 10th and 11th nerve. Now the question could be anything. They can convert a question like that: injury to which of the following nerve will lead to the convergent squint? Injury to which of the following nerve will lead to the loss of gag reflex? Injury to which of the following nerve will lead to the loss of lacrimation? Could be anything here. So you know that what nerve is that, and then you just need to know how to identify that nerve on the ventral aspect of brainstem. Usually neuroanatomy questions may, whatever images they give here, they're very predictable images, to be honest. They will give you a section, like one question on the sectional anatomy is inevitable. You'll get a transverse section or coronal section. Usually कोई ना कोई section आता है, and they will ask you to identify the structure in there. And the question boils down to just identification only. Question बहुत simple होगा. It's just you have to identify the structure. That's how what your primary goal is. That make sure that look at all the sections of the brainstem, look at the ventral and dorsal aspect of the brainstem, because you know that there are very good chances of getting a couple of questions from this part here. And the question will be all about just identifying the structure. The moment you identify that structure, when you look at the rest of the question, is pretty simple. That's a usual case. No, but the 7th nerve is not encircled. It's the 6th nerve only which is encircled there. Okay. Which statement are correct about the internal capsule now? This question is about the internal capsule. Look. Okay. There are certain questions which have been asked so many times over and over. मैंने वो इसमें question वो डाले ही नहीं इसके अंदर. Like the question from the dorsal aspect of brainstem, question on the facial colliculus, what nucleus is present there. This question has been asked over and over again, and everybody is discussing those questions, including I have discussed them in the one-shot video also. So I kind of excluded those questions which are unnecessary, just occupying the space of discussion here. Now, which statement are correct about the internal capsule here? Charcot's artery supplies the posterior limb, retrolentiform part contains optic radiation, anterior limb is having a corticonuclear tract supplying the upper limb and the face here, and internal capsule has projection fibers. Now, again, first of all, understand that's a new PYQ pattern, this new INI CET pattern here, in which they give the questions are pretty simple. If you people have seen the last year paper, absolutely simple questions were there. Bilkul simple questions the. The thing which actually made them difficult was this arrangement. They give you the multiple options to choose from. Now, as a question, problem क्या होता है कि when you have multiple options to choose from, that even if you know everything about the 3 options and you have no idea about one option there, that will create confusion. That what will be the right answer to this kind of questions here. So what they're doing, they're keeping the topic simple, but they're asking this, giving the answers where we have multiple options to choose from, like previous PGI pattern was there. And that way, what they're asking is that stick to the same important topics only, but make sure you read them in detail here. Stick to the same previous year topics, but read them in more detail here. Know everything about them so that you can fetch the answer to those questions here. So have a quick discussion on this, guys. I'll show you 2 images there. Now this is the internal capsule here. Let's have a quick look at this, and let's just focus on the things which I'm going to show you here. That's the anterior limb. That's a genu over there. That is a posterior limb. ये जो पीछे वाला part है, that is a retrolentiform part. From here you can see the fibers going out. That is a retro, behind the lentiform nucleus, retrolentiform part. And the one which is going below the lentiform nucleus, that is a sublentiform part. Retrolentiform, and then is a below sublentiform part here. Just 4 important or major tracts you need to keep in mind. Just 4. Corticonuclear. Now, upper motor neuron of most of the cranial nerves are here, guys. Look at that. Genu part. Genu ke andar we have a corticonuclear tract that is obviously supplying the head and neck muscles here. Corticospinal tract, upper limb, trunk, lower limb. Corticospinal tract is present where? In the posterior limb. That makes it very important. Posterior limb is important because corticospinal tract is passing through it, which is supplying most of the muscles in the body except for the head and neck part here. And look, When you say retrolentiform part, retro मतलब पीछे, sub मतलब नीचे, retro is behind, sub is below. So retrolentiform part is giving passage to what radiation? Optic radiation. भाई पीछे किसको जाना है? What is behind, guys? Visual cortex is behind. Striate cortex is present behind here. So the optic radiation will go from the retrolentiform part, from the posterior part. Sublentiform part, जो नीचे वाला part है, sublentiform part will give passage to the auditory radiation. Auditory, because auditory lobe, where auditory cortex is area number 41, 42. That is in the temporal lobe, वो नीचे present है. So these fibers have to go downward here. So sublentiform part gives passage to auditory radiation. Retrolentiform part gives passage to the optic radiation. Corticonuclear tract, upper motor neuron of cranial nerve, corticonuclear tract through the genu, and corticospinal tract from the posterior limb here. Just remember at least these 4 major tracts passing through the internal capsule, and I'm pretty sure that you will be able to answer the questions. Then comes the blood supply. Now, do not go into the detail of this blood supply here, the picture which I'm going to show it to you. Now, look at this, guys. It looks complicated in the first go here, but have a look at this once again. This is anterior limb, genu, posterior limb, retrolentiform part, and sublentiform part here. Now, as I said, don't go into the detail. They usually don't ask the names of these arteries here. Just need to know that what major artery is supplying where. Like anterior cerebral artery is supplying the anterior limb and the genu part. ऐसे याद रखते हैं. Anterior cerebral artery supplying the anterior limb and the genu here. Recurrent artery of Huebner and all. Forget about it. Anterior cerebral artery supplies the anterior limb and the genu. Posterior limb is supplied by the posterior cerebral, middle cerebral artery, you can see, middle cerebral artery, Charcot's artery coming from the middle cerebral supplies it. And posterior limb is also supplied by the direct branch coming from internal carotid, that is called as the posterior, this anterior choroidal artery, guys. There is a choroidal artery also which supplies it here. It's a direct branch. Can you see anterior choroidal artery there? So that anterior choroidal artery also supplies the posterior limb. You especially need to keep your eye on the posterior limb ki blood supply. I told you posterior limb is giving passage to corticospinal tract, pyramidal tract here. And that's why this is important part here. It is supplied by the middle cerebral artery branches, Charcot's artery mainly, and also by the anterior choroidal artery here. Retrolentiform part, जो पीछे present है, retrolentiform part is supplied by again by the anterior choroidal and the posterior cerebral, and this posterior cerebral artery also supplies the sublentiform part as well. It is supplying the sublentiform part as well. So you can just broadly see that which artery is supplying where, and especially keeping an eye on the posterior limb. That posterior limb is supplied by the branches of middle cerebral. It is supplied by the anterior choroidal, and some branches of posterior cerebral also supplies it in the caudal part as well. We can obviously go into the detail of all these and all. I know that the time is limited here. We can go into the detail of any of these structures and then we can keep talking about it here. But I know that your time is precious and abhi aapko chahiye ki you need to know the answers to the questions and you want to know that, okay, what can be asked from that topic, or agar question aa jaye, to how can I eliminate the options and I can reach the right answer here. Well, coming back to it, Charcot's artery supplies the posterior limb. True, middle cerebral artery ka branch hai. Charcot's artery supplies the posterior limb. That is correct. Retrolentiform part gives passage to optic radiation. Correct? Retro is behind. Optic radiation goes behind. So that is correct here. Anterior limb of the capsule of the capsule contains corticonuclear tracts of the upper limb and face. Anterior limb of the no, it's not anterior limb. It was a genu part. Genu mein it was a corticonuclear tract which is giving passage to the upper motor neuron of cranial nerve. So that is not correct here. An internal capsule has a projection fiber. Yes, internal capsule in fact is the best example of the projection fiber. The fiber, all the ascending tracts and descending tracts are going through the internal capsule only. So 1, 2 and 4 are correct. 1, 3 and 4 are retrolentiform part, internal contain optic radiation, guys. Correct statement. It's 1, 2 and 4. Yes, I'm sorry I've marked it incorrect here. That is 1, 2 and 4 which are correct here. I'll rectify this. I'll rectify this in the PDF that I'll send you. It's 1, 2 and 4. Thank you, Doc. That's all. That's because of all the love that you've given me. Thank you so much. So let's keep going. Marked cells in the given histological section is inhibitory too. Well, marked cells, question marked cell pe hi aayenge. If you get a picture on the cerebellar cortex here, the first thing is, guys, the only cell you can identify, and segregate is in the H&E staining, you can segregate these Purkinje cells only. Now, in the cerebellar cortex, we have 3 layers. We have a molecular layer. We got the Purkinje layer here, and look at these granules over there. It's a granular layer here. So I'm pretty sure that there is no problem in identifying it, which one is a granular layer. Granular layer looks granular here, and that's a very shanty layer. We have very few cells to be seen in that, and that's a Purkinje layer in between, which are having these large Purkinje cells, which are the last flask-shaped cells here. Now, as I said, the questions are, if the question is about a particular cell, then they usually will target the Purkinje cells only. That Purkinje cells are what type of cells? Are they excitatory? Are they inhibitory? What they're going to, where they are going? Are they coming out of the cortex or they staying into the cortex? So the questions like घूम फिर के Purkinje cell के ऊपर ही होते हैं. So marked cells in the given histological section inhibitory too. Now guys, the Purkinje cells are basically the only cells which are efferent from the cortex. No other cell will go out of the cortex here. All these cells are like they're having an internal circuitry only, but the only cell which is coming out of the cortex, the axon of the cell which is coming out of the cortex is a Purkinje cell. Let's have a very quick discussion on this here. The answer is deep cerebellar nuclei, but let's have a discussion on that. Cerebellar cortex is made up of three layers. We have a molecular layer, we got a Purkinje layer, and we got a granular layer. Three layers are layer. Molecular layer सबसे ऊपर है, granular layer, ground floor, granular layer नीचे की तरफ present है. Then molecular layer is having two types of cell which are called as the basket cell and the stellate cell, the two which I'm marking over there. The color is corresponding to the cell actually when you see this PDF, just make sure. Middle layer, this is a Purkinje cell layer, so obviously Purkinje cells, large Purkinje cells are there. And then granular layer, the spelling of the granular layer starts with G, is having all the cells or everything present in the granular layer, सबकी spelling G से start होती है. We have a granule cells and Golgi cells. We got a granule cells and Golgi cells. So three layers, and we have total 5 types of cell. Basket and stellate in the molecular layer, Purkinje cell in Purkinje layer, and granule and Golgi cells are present in the granular layer. And the thing is, out of the 5 types of cell, 4 of them are inhibitory, guys. Basket, stellate, even Purkinje, the one the question is asked on the Purkinje cell, that is also inhibitory cell, and that's a question asked. It is inhibitory to what? Inhibitory hoga na? That's an inhibitory cell here. And even Golgi cells, they are all inhibitory. Except for granule cell, which is an excitatory cell. And there's a reason for the granule cell to be excitatory, because there are some afferent tract which will come into the cerebellum, and the granule cell, these are the granule cells, look at this. These are the granule cells which will allow these afferent fiber to come inside and get connected to the Purkinje cell here. So they are excitatory. Now out of the 5 types of cell, 4 of them are inhibitory. That means Purkinje, this cerebellar cortex is the largest collection of inhibitory neuron. Nowhere in the entire central nervous system you'll find these many inhibitory neurons here. So it's the largest collection of inhibitory neuron. But as I said, the only cells which are forming the efferent from the cortex, not from the cerebellum, from the cortex, these are Purkinje cell. Purkinje cell will leave the cortex, and when they leave the cortex, they will obviously come into the white matter. And in the white matter, we have a nuclei like dentate, emboliform, vestigial, globose. Those are deep cerebellar nuclei. So the only efferent from the cortex are the Purkinje cells. These are the Purkinje cells over there. You can say they're coming out in there, and they are inhibitory to the deep. They are inhibitory cells, of course, and they're inhibitory to what? Deep cerebellar nuclei. And then deep cerebellar nuclei are the one which will actually go out of the cerebellum, which will influence the different, like they will go to the red nucleus, they will go to the thalamus, they will send the feedback to the cerebrum here. So all those efferent tracts which will come out of the cerebellum, they will come out of the deep cerebellar nuclei. So completely two different questions here. Efferent from the cortex, Purkinje cell se aayega. Efferent from cerebellum will come from where? Deep cerebellar nuclei. So the job of Purkinje cell is to have an inhibitory effect on the deep cerebellar nuclei which are present in the white matter of cerebellum. So that was the answer, that is deep cerebellar nuclei. So another question which is also last year question here, Purkinje cell se pareshan ho gaye to kuch aur naya pooch liya inhone, that which are the cells present in the molecular layer of cerebellum. Nothing much guys, molecular layer, topmost layer, we have the 2 types of cell over there, that is a basket cell and the stellate cell. The 2 supporting cells, stellate cells are the topmost cells here, and the basket cells are also there, which are dispersed everywhere in that layer. And these are 2 types of cell which are present there, 3 and 4. The basket and stellate cell are present in the molecular layer. Okay. The next one, guys, this is also a question asked, and this question was, actually it was a good question to ask, because the arrow they pointed on, it's a coronal section, the arrow they pointed on is on the fornix. Fornix को side से दिखाएं तो it is easy to like look at. The fornix will look like a bundle running like this, and so you can easily make out what is fornix here. So fornix, if you obviously take a coronal section, it will look like this dot only here. Now that is a corpus callosum, guys. That's corpus callosum, and extending from the corpus callosum is a septum pellucidum, the one which separates the 2 lateral ventricle. And just below that, these 2 white matter. Look at this. This is when I'm pointing at right now. These are the 2 fornix here. These are 2 fornix here. The question was, and this is the kind of question they love to ask. They will put an arrow on something, and they will ask you that the following structure is starting from where, ending where, which thalamic nuclei it will go into, what part of ventricle it forms here. So again, pointing, just emphasizing on the same thing कि question पूछना बहुत basic, But it all boils down to identification, whether or not you're able to identify that structure. Where does the marked structure arise from? The first marked structure. If you don't know what is a marked structure, the question is of no use. Well, guys, the marked structure is a fornix, and the beginning of the fornix is in the hippocampus. The beginning of the fornix is in the hippocampus. Now, if you look at this image here, you can see hippocampus over there. So, the pyramidal cells of the hippocampus, this is where the fornix fibers will start here. The pyramidal cells of the hippocampus will start hoंगे. That is a fornix. This bundle is a fornix here. It will go above, below the corpus callosum, below the septum pellucidum, and then it ultimately terminates in the mammillary body. They've asked the question on the origin, hippocampus. You never know, next time they will ask you where they terminate, and they terminates in the mammillary body, which is a part of or the component of limbic system only, guys. So remember, the fornix is a large white matter bundle. Fornix actually is an example of everything here. Like book says that it's a projection fiber. We have every kind of fiber in the fornix here. It is a commissural fiber also. We do have a, the commissural fiber also. It is an association fiber also. It is running in the same cerebrum, and it is an example of the projection fiber. It is projecting downward onto the mammillary body, to the diencephalon. So yes, they starts in the hippocampus there, and they terminates in the fornix here. The fibers of the fornix mainly from the pyramidal cells of the hippocampus. That again could be a question to ask here. They start from the pyramidal cells of the hippocampus and they terminate in the mammillary body. And look at this one important point here, guys. It constitutes the sole efferent of the hippocampus. The only efferent of hippocampus is a fornix only. There is no other efferent here. You never know what form they can ask you this question from. Like this could be another statement to ask here, that what is the only efferent from the hippocampus, and that is the fornix. Mention the arterial supply to the marked structure. Well, marked structure is the corpus callosum, and they have actually put a, let's say they have put an arrow on the rostrum of the corpus callosum, doesn't matter wherever they put the arrow on. Now the question is about what is the blood supply to the corpus callosum basically. Pure corpus callosum ki blood supply kya dekho. Guys, answer is anterior and posterior cerebral artery. Because when you look at the medial surface of the cerebrum, you know that the two main arteries supplying the medial surface is the anterior cerebral artery, and here we have the posterior cerebral artery here. Now let me just tell you a little more detail in this. If you look at this medial surface, you can see some blood vessels coming out from there. That's an anterior cerebral artery that you can see. That's an anterior cerebral artery, and this artery here is that running above the corpus callosum in this sulcus over there. That is called as a pericallosal branch here. That is an anterior pericallosal artery or anterior pericallosal branch, and this anterior pericallosal branch is the one which supplies the most of the part of the corpus callosum, including the rostrum, the genu, the body part, except for the posterior part, the splenium part. Ab splenium is posterior, piche, posterior part. So it is supplied by the branch of what artery only? Posterior cerebral artery. So it's a posterior cerebral artery which will give off these dorsal branches, or you can say posterior pericallosal artery, and that is the one which will supply the splenium of the corpus callosum. So splenium of corpus callosum ki blood supply come from posterior cerebral, and remaining corpus callosum is supplied by the anterior pericallosal artery which is come from anterior cerebral. So overall corpus callosum is supplied by both anterior cerebral as well as posterior cerebral artery. Next question, fibers from the labeled structure ends in which thalamic nuclei? This also is a recent question only. And again, you can make out that this question is again just the examiner wants to ask you whether or not you're able to identify the structure here. So sections, guys. Again, emphasizing on this transverse coronal section. Sections zarur karne aapko. You have to identify the structures of the section, and the question will be pretty simple based on that here. Now, they have put an arrow on the floor of the third ventricle, guys. The arrow is on the floor of third ventricle, and on the third ventricle floor, on the floor of third ventricle, this here is a mammillary body there. That is a mammillary body. Mammillary body is forming a floor of third ventricle, the same mammillary body where the fornix fibers were ending here. Now, mammillary body projects into which thalamic nuclei? Thalamic connections are important. If I just put a thalamus here, answer is anterior thalamic nuclei. Let me just show it to you. Now, these are the thalamus here, and look at the main thalamic nuclei there. You can see the anterior, that's an anterior group of thalamic nuclei, that's a medial group of nuclei, and this whole is a lateral group of thalamic nuclei. सबसे बड़ा nucleus pulvinar होता है, that is on the back side here. Pulvinar nucleus is the largest nucleus there. But see, important is anterior thalamic nuclei, and all these nuclei जो कि नीचे present, all these nuclei which are present in the ventral tier, ventro-anterior, ventro bahar ki taraf, ventrolateral, and then ventroposterior, which are having two parts. One is VPL and VPM, ventroposterior lateral, and the one inside will be the ventroposterior medial. Now the question here was about the mammillary body. I hope that you people have read about these, the major thalamic nuclear connection here. If you've not read about them, make sure that please read about all these ventral tier nuclear connection, guys. VPL, VPM, VL, VA. ये जरूर पढ़ने हैं आपने. Make sure that, forget about this dorsal tier nucleus, forget about this medial nucleus here, but at least make sure that read these ventral tier nuclei connections. Well, in our question, it says that mammillary body, that pointed structure was mammillary body, and you write mammillary body projects into the anterior thalamic nuclei. This tract is called as a mammillothalamic tract here. But notice something, that the examiner is asking the question nowadays based on the limbic system, the components of the limbic system. Phonics pe question pucha pehle, that was a part of limbic system. They've asked a question on the mammillary body, part of limbic system here, to which thalamic nuclei are connected to. Anterior thalamic nuclei is a component of limbic system. So this Pape circuit of emotional integration is important here. So I'm sure you read about this in the physiology also, that mammillothalamic tract projects into the anterior thalamic nuclei. Anterior thalamic nuclei, the gives of thalamic radiations, which will go into the cingulate gyrus. Cingulate gyrus is above the corpus callosum only. Cingulate gyrus is connected via cingulum to the hippocampus and parahippocampus. And hippocampus is connected to mammillary body, this fornix, we saw that abhi. Hippocampus is connected via fornix into what? Mammillary body only. So look at the entire circuit here. So mammillary body projects into the anterior thalamic nuclei, that is mammillothalamic tract. Thalamic radiation goes into the cingulate gyrus, which is just above the corpus callosum, that you can see on the medial surface. Cingulate gyrus is connected to the hippocampus around the corpus callosum only. All these areas around the corpus callosum, in the core, they are all parts of limbic system, the components of limbic lobe. And hippocampus via fornix. Fornix fibers, remember that? Fornix originates from hippocampus and terminates in mammillary body. So that is a part of the limbic system, or you can say it's a Pape circuit here. So for this particular question, yes, the answer is anterior thalamic nuclei. Okay, question number, the next question, lower motor neuron of which cranial nerve is expected to be seen in the marked region in the given sagittal section? Now please understand that you know that most of the cranial nerves are coming out from front of the brainstem here. Third nerve was coming out from here, interpeduncular fossa. Then from the pons, it was a fifth nerve coming out, pontomedullary junction 6, 7 and 8. And all the nerves are coming from the ventral aspect here. Now there are only two possibilities to get a question from the dorsal aspect. Either they will put an arrow somewhere behind the pons, and that you can see it's a fourth ventricle, guys. That means the arrow is basically pointing out in the floor of fourth ventricle here. Or they might put an arrow behind the midbrain here. So दो ही possible answer हो सकते हैं यहाँ पे. If the arrow is placed somewhere in the pons, behind the pons here, within the fourth ventricle, that is the floor of fourth ventricle, then obviously they are trying to ask you about the facial colliculus, and you know facial colliculus is found by the lower motor neuron of facial nerve. If you look at this image here, if you look at this picture, देखो, here is the image here, that is a pons, this is medulla oblongata, that is midbrain. Now that's a fourth ventricle present behind here, that's a fourth ventricle. Now I hope you can see the seventh nucleus is there, which is inside, but seventh nerve is winding around this sixth nucleus and then goes from the front here. That means the facial nerve fibers are the one which are projecting on the dorsal aspect of the brainstem in the floor of fourth ventricle, forming the facial colliculus. So that facial colliculus is by the lower motor neuron of facial nerve. So if the arrow is placed in the floor of fourth ventricle, then seventh nerve is your answer there. But if the arrow is placed somewhere there, below the inferior colliculus, can you see superior colliculus there and inferior colliculus? That's a dorsal aspect of midbrain, also called as the tectum of the midbrain. So we have a superior colliculus, inferior colliculus. So if I put an arrow somewhere behind the inferior colliculus, below the inferior colliculus, so obviously the fourth nerve will be coming out from there. Like look at this picture here. You can see that's a fourth nerve here, the trochlear nerve, the only nerve which comes out from the dorsal aspect of the brainstem here. So some people said the arrow was in the floor of fourth ventricle, some said it is in the behind the midbrain here. Two possibilities hai. Just make sure that you find out that where the arrow is placed here. If it is in the floor of fourth ventricle, you got to go with the seventh nerve. But if it is behind the midbrain, below the inferior colliculus, then fourth nerve, the trochlear nerve, will be your answer. A woman presented to the hospital with a loss of sensation in the right and the lower, right upper and the lower limb. She also complains of shooting pain from her fingers and right shoulder and burning sensation. Motor functions are normal. Which of the following structure is likely to be involved here? Now guys, again, this is a very simple question. It's a question of the thalamic pain syndrome. And the thing is that you just need to identify thalamus in this. If you look at this image here, again, when the question was asked, it was just, the examiner was just wanted to know that whether or not you can identify that part of the brain in this here. So when you look at this arrow, this is present in the floor of the fourth, this lateral ventricle, where we have a caudate nucleus here. B over there, that is the thalamus. C, you can see that stained area over there. That is because of the substantia nigra there. And then D obviously is that is put on the cerebellum part here. That is placed on the cerebellum here. Now B is the arrow which is placed on the thalamus, and I'm sure you all people have read about the thalamic pain syndrome in the medicine part also, in the physiology also. The thalamic pain syndrome, in which we have like contralateral hypersensitivity will be there. And see, it is said in this picture they have pointed out the structure of the left side here, and that's the sensation of the right side is lost here. Right upper limb, lower limb sensation are lost here. Okay. And also there is a hypersensation. There is shooting arm from the finger and the right shoulder. So they have a hypersensitivity. That is the cause of the thalamic syndrome. Like 8 to 10% cases of any stroke, they do have this, the thalamic pain syndrome here. So in this question, what I was told, that and in fact this is what they're doing nowadays, that when they arrange the options, they do this also, that like they put an option A and don't write A in front of A. Like they write in front of A, they write the B, in front of B they write a D like this here. That just to play with your mind only. Like A, B, C, D, they could have write it like simple and straight only here. But we know that B is marked as a thalamus there. So you have to mark B as an answer, and B is A, option A over there. So they also, they do play they do play these kind of mind games also. Just be. Yes, exactly. That's a Dejery-Rousey syndrome. You're absolutely right. That's a thalamic pain syndrome, and that is the answer to this question. Thalamus. You just need to identify thalamus in this. Motor function is normal. It's a clearly mentioned motor functions are normal. So it's the thalamic pain syndrome. Okay. Next in the line, question asked was arrange the following cells in the order of basal to the luminal side here. So basically the question is about that how these the different stages of spermatogenesis are placed in the seminiferous tubule. So when you take a section of the seminiferous tubule, then how do you see they're arranged here? So the spermatogonium, the spermatozoa, the primary spermatocyte, spermatid, maybe secondary spermatocyte, all given here, and then you have to arrange them here from the basal to luminal side. Again, the question is very simple, very basic, but sometimes we just get confused with this terminology only, and we just have to find out the right sequence here. Arrange the sequence, right sequence. That's the new trend. That's something that INICET love to ask. कि questions दिए होंगे आपको पूछेंगे, arrange them in the sequence. Auditory pathways asked twice about this. Arrange the auditory pathway in the sequence here, and that's why I always say that all these secretomotor pathways of the gland, you should remember them, because they can ask you these questions also. That arrange them in a particular sequence here. Now for this question, guys, answer is like option B only. We have a spermatogonia which are present close to the base. Then we have this primary spermatocyte, then there will be secondary spermatocyte. Then we got this spermatid, and then the spermatid will undergo the spermiogenesis, and the spermatozoa, the typical sperm, will be formed, which is toward the luminal surface here. Have a look at this picture for a quick review here. That's a picture of a seminiferous tubule here, and these are the Sertoli cells. Like this brown color here is for the Sertoli cells. And look at these junctions between the Sertoli cell, guys. These junctions between the Sertoli cell, these are tight junctions or zona occludens, and they are the one which are forming the blood-testis barrier. Blood-testis barrier, all these barriers में थोड़ा सा misnomer है. Generally, when we say blood-brain barrier, blood-CSF barrier, blood-thymic barriers, those barriers are made up of the tight junction between the endothelial cells. But here the tight junction is between the Sertoli cells here. Sertoli cells, that is called as the blood-testis barrier, also called as the Sertoli barrier. Now what this blood-testis barrier is doing, it is basically dividing the compartment of the seminiferous tubule into the different, it is basically compartmentalizing the seminiferous tubule only. So we have different stages of this spermatogenesis held inside. Like you can see the spermatogonia toward the basal side here. Then we have primary spermatocyte. Then we have secondary spermatocyte. So they will keep on maturing, and they will keep going toward the lumen here. Then we have this spermatids, and then spermatids will undergo the spermiogenesis, and then we have the formation of spermatozoa. And उसके बाद फिर spermiation होगा, and spermiation is when these sperms are released into the lumen of seminiferous tubule here. So it's a very simple and straight question. They just wanted to know that whether or not you know that how to arrange the cells from the basal to the luminal surface in the seminiferous tubule. Okay, the next question, which of the following are derived from the marked structure here? Again, this is one question which I again personally feel very strongly about it, that this question could be repeated, or the kind of question will be repeated here. Neural crest cell is something which is never out of the fashion. Just know that here. Like in the subject like anatomy, कुछ ज़्यादा update तो है नहीं, things remains the same only. So they keep on asking the same question over and over again, but they keep on changing the language of the question dramatically every time. But neural crest cell is something for which some updates will keep coming and keep going. So that's why I very strongly feel that neural crest cells पे question आते थे पहले भी. This was asked last year also, and again they will be asking the questions on neural crest cells. Now, when the people said ki, okay, sir, we got confused that whether it's a arrow placed on the neural crest cells or neural tube here, if they have to ask you the question on the neural tube only, why would they put an arrow in any edge or any margin here? They'll put an arrow on the neural tube itself, na? So that's a neural tube there. That's a notochord below, which is the one which stimulates the ectoderm to form the neural tube. That is the ectoderm, and at the junction of the neural tube and ectoderm, we have these cells which are segregating from the crest of the neural fold, and they are a different entity now. Neural crest cells is a different entity now. They have the property of ectoderm also. They have the property of neural tube also. So that's why they give rise to the neuronal structures as well, and they give rise to some mesenchymal structure as well here. So these neural crest cells, right now, that when they put the arrow here in here, guys, neural crest cells are squeezed in this portion here. Later on, they will be segregated from this part here, and then the neural crest cell will migrate to the side of the neural tube and will also migrate to the different areas of the body. So that's a neural crest cell that you will see at the junction of the neural tube and the ectoderm. And neural crest cells will give rise to what? Now, this list can go on and on for the neural crest cell, guys. So obviously, you cannot just sit and read everything about the neural crest cell derivative. Possible nahi hai wo. So there are some important derivatives which I've given you the list in this one-shot video also. And again, I would say that just please go through that list if you have not read about the neural crest cell well. Out of these, odontoblast, sympathetic chain, melanoblast and melanocytes, yes, they are all derived from the neural crest cell. And even this conotruncal septum. See, conotruncal septum is a question asked in the INICET exam separately also, that where it is derived from. Conotruncal, it is a combination of conus and truncus. Conus and truncus, guys. Truncus arteriosus is a part of heart tube, and conus is a part of heart tube. Truncus arteriosus will give rise to the ascending aorta and pulmonary trunk, and conus is basically forming the smooth outflowing part of the ventricles here. So दो septum होते हैं, one is called as a bulbar septum and one is called as a spiral septum. There are two septum, one is dividing the interventricle, one is dividing the ventricle, that is a bulbar septum, and the septum dividing the truncus arteriosus, that is called as a spiral septum. दोनों को मिला के हम बोलते हैं conotruncal septum. So conotruncal septum इसमें दो चीजें होती हैं, conus and truncus. It is dividing the conus part and the truncus part, and that is also an important derivative of the neural crest cell. So if let's say the neural crest cell failed to migrate, so conotruncal septum बनेगा ही नहीं. That will lead to the patent truncus arteriosus also. So yes, from this here, the answer is 1, 2, 3 and 6 here. Just a quick list over there, guys. Neural crest cells, derivatives. देखो ये वाले जो important derivatives हैं उनको याद रख लो at least. And I feel that although there are more derivatives than this, but this will be good enough at least to eliminate the wrong options here. The point is, if you cannot find the right answer, we can eliminate the wrong options there. So peripheral nervous system. The first thing is, the moment you think of neural crest cell, think of peripheral nervous system here. Ganglion. Whichever ganglion comes into you in front of your eyes, answer neural crest cell. Parasympathetic ganglion, trigeminal ganglion, sympathetic chain, dorsal root ganglia, they're all part of peripheral nervous system. So the moment you think of peripheral nervous system, it is derived from the neural crest cell. Entry plexus, peripheral nervous system. Schwann cells will do the myelination for peripheral. Oligodendrocytes are derived from the neural tube. That's a Schwann cells because they're doing the myelination for peripheral nerves. So look at these, the three which I marked in the red color there, that is all corresponding to the peripheral nervous system. Adrenal medulla, guys. Adrenal medulla is also by the neural crest cell. Adrenal cortex बनता है intermediate mesoderm से. Adrenal cortex is by the intermediate mesoderm, and adrenal medulla is by the neural crest cell. C cells, parafollicular C cells, very important. They've asked the question on this here. We just saw melanos. In fact, all the pigment epithelium, melanoblast, melanocyte, all pigment epithelium are from the neural crest cell except the retinal pigment. Retinal pigment directly neural tube से आता है. Retinal pigment is from neural tube only. Most of the skull bones, odontoblast, pharyngeal arch cartilages, dermis of head and neck here. Rest of the dermis in the body is coming from mesoderm. Paraxial mesoderm, lateral plate mesoderm. Head and neck mesoderm is coming from the head and neck dermis is coming from the neural crest cell, and the conotruncal septum we just said here. Now, although this may not be the right way to look at it, but look at this. When you look at the majority of the structure in the head and neck, guys, most of the head and neck structures, which elsewhere in the body are derived from the mesoderm, in head and neck they are derived from the mesenchyme of neural crest cells. Like if you think of a bone anywhere else, the bones are coming from mesoderm, paraxial mesoderm or lateral plate mesoderm, right? But in head and neck, most of the skull bones are coming from where? Mesenchyme of neural crest cells. Cartilages are derived from where? Mesoderm, rest of the body. But pharyngeal arch cartilage come from where? Neural crest cells here. Dermis in rest of the body come from where? Mesoderm, but in head and neck, dermis is coming from where? Neural crest cells. So majority of these head and neck structures, which corresponding structure in rest of the body are coming from the mesoderm in head, neck and face, most of them, not all of them, but most of them are coming from the mesenchyme of neural crest cells, from the neural crest cells. Okay. Chalo guys, next question, what is the embryological origin of the blue mark structure there? Well, first of all, what is the blue mark structure? As I said, sometimes the question boils down to the identification only. Abhi blue mark structure nahi pata to fir aage kya karna hai? Well, what is the blue mark structure, guys? That's a posterior mediastinum we are looking at. And what you can see the aorta there, you can see the trachea bifurcating. Basically, that is present on the right side, and that's the azygous vein which is marked there. Now, I don't know what kind of image was given in the exam. Was it a side view or something? But azygous vein was given. And azygous means unpaired. That's a vein present toward the right side. Azygous vein ko identify karna hai, to keep it in mind that you got to see close to the vertebral column. It's very, very like posteriorly placed structure. It's a posterior mediastinum structure here. And azygous vein being unpaired, you will find it on the right side only. On the left side, we have hemiazygous and accessory hemiazygous. So there is a azygous vein. Now again, this is not the time that I can completely go into the development of the entire venous system. Itna time na aapke paas hai to understand this. But just to tell you guys, azygous vein is developing from the supracardinal vein. It is developing from supracardinal vein here. Now, let me show you the picture here. Don't get confused. It's the last time. I don't want you to go. If you've not read about the venous development, isko nahi karna abhi. Just don't go too much into it here. Understand one thing, guys. There are three veins which are in this part here. We have a posterior cardinal, we have a supracardinal, and we have subcardinal. Posterior cardinal, supracardinal, subcardinal. Posterior cardinal veins are the one which are carrying the blood from the lower half of the body. And these are the veins which gradually need to be replaced. The new veins have to form because kidneys are developing, gonads are developing, suprarenal gland is developing, so many structures on the posterior wall are developing. So new veins, they have to come into the picture. We need to replace this posterior cardinal vein. And that's why we have a new vein coming up on developing in this region here, in the lower part here. That is called as a subcardinal vein. We have supracardinal vein. Subcardinal vein will contribute mainly to the inferior vena cava. Mainly, I'm not saying mainly to the inferior vena cava. And supracardinal vein will contribute to the azygous and hemiazygous system. So, abhi ke liye itna yaad rakh lo at least कि subcardinal vein, the word subcardinal or sacrocardinal जब आपके सामने है, sub और sacrocardinal, that is for the inferior vena cava. Supracardinal is for the azygous vein. Azygous vein will develop from the supracardinal vein, although they say it is actually from the supracardinal vein and some part is by the posterior cardinal also. But again, the major component is the supracardinal vein, and looking at that what time we are in right now, so I would say that at least kind of mug it up here, although I hate to say that supracardinal vein actually gives rise to the azygous vein. Hello Rajat sir, good to see you. Always good to see you. Great to see you. Okay. Okay. Next question. A child with absent thymus and present with tetany, actually, which of the following marked area in the given image is defective in condition here? This is again a question asked twice, both the time image-based question here, and it's a question of pharyngeal arches. Now, something in the embryology that you just cannot miss, in the embryology, is the pharyngeal arches. If you pick up the paper of the last 5 years, and you will find a question on the pharyngeal arches in a different form, they'll ask it, keep on asking it to you. Pharyngeal arch arteries, they've asked this. Pharyngeal arch nerve coming from where? Neural crest cell, they've asked this question. This question about the absent thymus and hypoparathyroidism. They've asked the question about recently, in fact, the NEET also, they asked the question, the patent ductus arteriosus. Dr. Rajat only told me about that question was asked. So all these are about pharyngeal arch questions basically. Recurrent laryngeal nerve. Left recurrent laryngeal nerve is longer, right recurrent laryngeal longer. It is again a question of pharyngeal arch arteries only. So pharyngeal arch is something embryology mein kuch padho na padho, at least make sure that please make sure that read the pharyngeal arches in and out, because you are going to get a question from there. Now guys, this is a picture of pharyngeal arch in which outside we have a cleft here. All the clefts are obliterated because of the cervical sinus. Only first cleft over there, the first cleft will be remains, which will give rise to the external auditory canal. Pouches, all of them are cysts. That's the first pouch there, second pouch, third pouch, which is the answer to this question, and then we have a fourth pouch here. So answer is third pouch here, but let's have a very quick look at about these pouches. Now, that's again a coronal section through the pharyngeal arches, a very schematic picture here. So all these are the clefts outside, and all the clefts we said will get obliterated. Only the first cleft will remain. Pouches, first pouch, second pouch, third pouch, fourth pouch. Pouches, all of them will persist here. Now, first pouch First pouch, pouches are endodermal, of course. First pouch will give rise to what? Inner layer of tympanic membrane, middle ear cavity, and think of the extensions of the middle ear cavity, like eustachian tube, mastoid antrum lining, that is all coming from first pouch. Second pouch, guys, second pouch between second and third arch, that will give rise to the palatine tonsil. Strictly speaking, the lining epithelium of the palatine tonsil will come from the second pouch. Third pouch, which is the answer to our question, third pouch will give rise to the thymus and also to the inferior parathyroid gland, thymus and the inferior parathyroid gland there. And then we have the fourth pouch, which will give rise to the superior parathyroid gland. Now we do not have fifth pouch, but we have some remnant of the fifth pouch, which are residing with the fourth pouch here only, and that is nothing but the ultimobranchial body. That is nothing but the ultimobranchial body. And it's a neural crest cells which will migrate into the ultimobranchial body, and I mean, it's like the question is asked that neural crest cells, what gives rise to the parafollicular C cells? So it's a neural crest cells. Neural crest cells are the one which will migrate to the ultimobranchial body, and that's where they will give rise to the parafollicular C cells. Well, our question here about the absent thymus. Absent thymus, hyperparathyroidism, that's a guy's one of the most common microdeletion syndrome here. You all know about the DiGeorge syndrome here, and it's a DiGeorge syndrome in which you have this absent thymus and hyperparathyroidism. So our question was about this only, and if you have to choose between, because third pouch is the one which is actually giving rise to thymus and inferior parathyroid. So if you got to choose between the third and fourth pouch, then third pouch obviously is your best answer in this here. Another last year question, incorrect match about the pharyngeal arch arteries. Again, pharyngeal arches, guys, pharyngeal arch arteries, pharyngeal arch nerve, pharyngeal arch musculature, everything about pharyngeal arch is important. Now, first arch, maxillary artery, second arch, hyoid stapedial, third arch giving rise to the right subclavian proximal part, fourth arch, I'm sorry, and sixth arch to the arch of aorta. Well, obviously the incorrect match here is the sixth arch artery giving rise to arch of aorta. But this being such an important topic, so I think we should invest like 5 minutes to this. Let's have a quick look at these arch arteries here. ज़्यादा detail में नहीं जाना है. You don't have to think about every single component of arch of aorta. Just think about the major thing here. Now let's just keep looking at the one picture at a time here. You can always read this part later if you want. Now guys, look at this. The fourth arch artery, the left fourth arch artery will give rise to the arch of aorta. Now arch of aorta is having other components also, but the main component of the arch of aorta is the fourth arch artery of the left side. Obviously arch of aorta toward the left side. Then continuing downward, descending aorta, that's dorsal aorta. The left side dorsal aorta will give rise to the descending aorta mainly. That over there, the one which is marked over there, brachiocephalic artery. Now we know brachiocephalic artery has to go toward the right side. So it's the right horn of aortic sac. That's an aortic sac there, and we have a right horn of aortic sac, which obviously is turning toward the right side, and then again will divide into the common carotid and subclavian. So just the right horn of aortic sac will give rise to brachiocephalic. Fourth arch artery of the right side, important. Fourth arch artery of the right side will give rise to right subclavian artery. They do ask question on the right subclavian artery, abnormal right subclavian artery also. So right side fourth arch artery will give rise to right subclavian artery. Left side ki subclavian artery directly come from the dorsal aorta only, from the segmental artery, intersegmental artery. Third arch artery goes like this. Third arch artery gives rise to common carotid, and then continuity will give rise to the internal carotid. Common carotid and internal carotid from third arch. You can see that's a common carotid there, and the continuity over there is an internal carotid. And sixth arch artery, important, a recent question guys. Sixth arch artery, the proximal part of the sixth arch artery forms the pulmonary artery, but the distal part of the left sixth arch artery gives rise to the ductus arteriosus. And that was a question of this NEET also, that patent ductus arteriosus is because of what? The patent ductus arteriosus when we have this patency of this distal part of the left sixth arch artery, left sixth arch artery here. और इस question को तो अलग-अलग तरीके से पूछ चुके हैं. This ductus arteriosus will become ligamentum arteriosum, but an anatomical structure will be there. That means something is there. It will not disappear. Like the distal part of the sixth arch artery, right sixth arch artery will disappear, but the distal part of the left sixth arch artery will stay. Maybe patent ductus arteriosus, maybe ligamentum arteriosum, and that's the one which will not allow the recurrent laryngeal nerve to go above. So we have a long left recurrent laryngeal nerve because it never got a chance to go above the distal part of the left sixth arch artery. Distal part of right sixth arch artery तो है ही नहीं, गया गायब. So that's why this recurrent laryngeal nerve will come below the fourth arch artery, and we just said fourth arch artery is giving rise to what? Subclavian, and that's the reason your right recurrent laryngeal nerve is present just below the subclavian artery only, जबकि left recurrent laryngeal nerve is going all the way below the arch of aorta and ligamentum arteriosum. Right? First arch artery, guys, First arch artery, we just have the remnant, that is a maxillary artery. And the second arch artery, also remnant, we have that is stapedial and hyoid artery. The one you see the maxillary artery, first arch artery, hyoid and stapedial artery, second arch artery, that is correct. Fourth arch artery giving rise to the subclavian artery, proximal part of right subclavian artery, correct here. But arch of aorta was developing from the left fourth arch artery. That was a mismatch. Okay, next we have a couple of questions from this from the upper limb first. Now, which part of the scapula is seen in the infraclavicular fossa? They do ask some questions nowadays about that, about the structure, about the palpation, a little about the surface anatomy. Zyada nahi, just don't bother too much about it. Nothing like out of the blue, nothing something that you cannot guess of or think of. Now, which part of the scapula is seen in the infraclavicular fossa? Now, if you look at the infraclavicular fossa, guys, we have the two strong muscle over there. One is the pectoralis major muscle is there, and then we have anterior fiber of deltoid. Now, because of these muscles, well, ideally, nothing can be felt below the clavicle if it's just a very superficial palpation there. Now, if you go toward the lateral side, below the lateral end here, below the clavicle, in the infraclavicular fossa, I will say, in the lateral 1/3 of the clavicle, if you go below the clavicle here, we have an anterior fiber of deltoid. But in the deep palpation, if you relax your shoulder, and in the deep palpation, you can actually feel a bone there, and that you're feeling is a coracoid process. So coracoid process, which is marked as B over there, coracoid process is something which will be felt in the deep palpation on the lateral side of the infraclavicular fossa. Not this superior angle of scapula, not that infraangular tubercle, and of course, no chance of acromion process, which is at the back. So B, that is a coracoid process. In the subclavian artery block at the outer border of the first rib, which of the following arteries helps in maintaining the circulation of the upper limb? Another way of asking those questions, guys, giving multiple options, and you have to choose in between them. Well, this topic is anyways important here because it is about the scapular anastomosis. Shoulder joint is the most commonly dislocated joint in the human body. And once the shoulder joint dislocates, there are very good chances that the head of the humerus will compress the axillary artery. The second part of axillary artery can get compressed. In that case, agar axillary artery compress ho gaya, then obviously the upper limb blood supply will be hampered. So scapular anastomosis comes into the picture here. Now, scapular anastomosis is an anastomosis between the first part of subclavian to third part of axillary. Even if you remember this one statement here, aapka kaam ho jayega isse. Scapular anastomosis is an anastomosis between the first part of subclavian to third part of axillary artery. So if you just narrow down that what are the branches coming from first part of subclavian and what branches are from third part of the axillary artery. So before I show you the pictures, think about the branches, guys. I know you read about it here. Just say these branches to yourself. What are the branches coming from first part of subclavian artery? VIT, vitamin, VIT. V is vertebral artery. वो तो गया ऊपर. I is internal thoracic. वो गया नीचे into the thorax. What is left? Thyrocervical trunk. So what we need, one is thyrocervical trunk. Thyrocervical trunk is from the first part of the subclavian artery. Third part of axillary artery. Third part of axillary artery is having anterior circumflex humeral artery, posterior circumflex humeral artery, and they are anastomosing with each other. So what is the main artery left over there? That is the subscapular artery. So thyrocervical trunk yahan se and subscapular artery from the axillary artery. Now these are the two major arteries which will give the branches to anastomose at the dorsum, that is the scapular anastomosis. Have a look at this picture. It's a hand-drawn diagram only. I'll come to the answer here. Look at this. Now, if you look at that, that's a thyrocervical trunk there, right? So that's a thyrocervical trunk. And thyrocervical trunk is having a branches. One is inferior thyroid artery, which we today talked about in detail. Inferior thyroid artery supplying thyroid gland, esophagus, parathyroid gland, all that, spinal cord. Then we have an artery called a suprascapular artery. Iska naam hi suprascapular artery. Obviously, suprascapular artery will participate in this anastomosis here. One. Number two, then we have transverse cervical arteries. Transverse cervical artery usually divides into a superficial branch and deep branch. Now that's a deep branch of transverse cervical artery which is running along the medial border of scapula. So guys, deep branch of transverse cervical, also you can say dorsal scapular artery. So deep branch of transverse cervical or dorsal scapular and suprascapular artery, ये तो contribution हुआ कहाँ से? Thyrocervical trunk से. Axillary artery third part gives off subscapular artery, and that is reaching the inferior angle also and giving a circumflex scapular artery which is participating in this anastomosis. So these are the arteries which are participating in this anastomosis here. So basically thyrocervical trunk is contributing to anastomosis, and all these branches, look at these branches named scapular here, suprascapular, then we have dorsal scapular, subscapular, circumflex scapular, scapular. All these scapular anastomosis found by these arteries here, right? So the question is that which of the following arteries is maintaining the collateral circulation? So suprascapular artery, yes, because it is coming from where? Thyrocervical trunk. Superior thoracic artery, no. Superior thoracic artery is coming from first part of the axillary artery. It does not participate in the scapular anastomosis. Forget about it. Thyrocervical trunk, yes, the main trunk from where the suprascapular artery is coming from. And subscapular artery, of course, it is coming from the third part of axillary artery. So you got to see that picture here. Look at these arteries which are participating in this anastomosis. Think of the thyrocervical trunk, think of the subscapular artery and the branches, and you get the answer here. So answer is 1, 3, and 4. Agar if you find any mistake in any of the key or something, guys, I'll rectify it. So don't worry about it. Okay. Now moving on. Now this is a question which actually I think that some of you might get it wrong for a reason. See the muscle attached to the marked area. Now when you look at this picture here, what is the muscle attached to this marked area, guys? Is it abductor pollicis longus? Is it palmar interosseous? Is it a opponens pollicis or is it a flexor pollicis brevis here? Palmar interosseous तो हो नहीं सकता. Palmar interosseous तब होता है जब अंदर की तरफ होता है. Palmar interosseous तो नहीं है. Forget about the palmar interosseous. I wanted to just give me some answers, guys. I want just only for this question I want to wait for like 10 seconds and you give me some answers here. In the meantime, I can have a water break. Come on. Give me some wrong answers. हाँ मुझे पता था कि आप ज़्यादातर ये बोलोगे. No, my dear, answer is not C. I'll tell you why opponens pollicis is not the answer. देखो, opponens pollicis would have been the answer to this question if the arrow was on the shaft of the first metacarpal. Arrow is not on the shaft, it is on the base of the first metacarpal. And base of first metacarpal, it gives attachment to the abductor pollicis longus. Have a look at this. The answer is abductor pollicis longus. It's not C. I knew that most of you will say C, और आप बोल ही रहे C बोल रहे हैं काफी लोग इसमें. देखो, this muscle abductor pollicis longus, it's a muscle which is coming from the back of the forearm. Now this is a muscle, look at this, if I trace this tendon here, it is going to the base of the first metacarpal. Base of the first metacarpal. Bennett's fracture में tendon भी involved होता है यहाँ पे. ठीक है? If the question was about the shaft here, because I know that opposition of the thumb is done by the metacarpal, the rotation of metacarpal. But you rotate the metacarpal because opponens pollicis muscle is attached to the shaft, not to the base. Look at that. That's abductor pollicis longus. This muscle here is the opponens pollicis. Now, opponens pollicis is attached to the shaft over there. So please be careful in this question. Is the question asking about, now there are three possibilities of this question here. If the arrow is at the base of the first metacarpal, it is abductor pollicis longus. If the arrow is on the outside, lateral side of the shaft of the metacarpal, first metacarpal, then answer is opponens pollicis. But if the arrow is on the inner side of the shaft of metacarpal, then answer is a palmar interossei. Palmar interossei muscle will originate from the metacarpal only. But agar wo arrow andar ki taraf hota hai. Have a look at this picture once again. This one is the attachment for abductor pollicis longus. Had it been this arrow be here, then the answer would have been the opponens pollicis. If the arrow was on the inner side of the shaft over there, then the answer would have been the first palmar interossei. For this question, answer is abductor pollicis longus. Okay, chalo. Moving on. The book test is done to assess which of the following. Well, book test, I'm pretty sure you all read about this in the ortho class also, that book test is done to check the integrity of the ulnar nerve. Well, what is this book test? What is this Froment sign, if I may quickly discuss with you here? Now, look at this. When you ask someone to hold something like something book or something in their hand, then obviously they will use the thumb against the lateral side of their index finger, along the lateral side of their index finger here. And that is done by this adduction force is coming from the adductor pollicis muscle. Your thumb is flat. You're holding the object. You don't have to curl your thumb because the adductor pollicis, a solid muscle there, adductor pollicis can do that, and adductor pollicis is supplied by the ulnar nerve. So if the ulnar nerve is intact, this muscle will take care of holding the object in between the thumb and the index finger. But if the adductor pollicis is not working because ulnar nerve is not working, then what will happen? You will do a trick movement, and the trick movement is you will curl your finger, guys. You will flex the interphalangeal joint of the thumb. And interphalangeal joint of the thumb को आप इसलिए flex कर रहे हैं because adductor pollicis is not working, and you still want to hold the object in between the thumb and the index finger. So you will curl your thumb, and curling of the thumb is possible by the tendon or by the muscle which is reaching the distal phalanx. And that muscle which is reaching the distal phalanx of thumb, flexing the thumb, is flexor pollicis longus. Flexion of the interphalangeal joint of thumb is done by the flexor pollicis longus, and that is supplied by the anterior interosseous nerve. So basically, when the ulnar nerve is not working, then you're using your median nerve or anterior interosseous nerve to compensate for it. And how you do that? By curling the thumb, by making this flexing this interphalangeal joint of thumb. You're basically using your flexor pollicis longus if your adductor pollicis is not working, and that is positive Froment sign. That is a book test then, and that is for which nerve? That is obviously for the ulnar nerve. So you're basically testing the ulnar nerve, kaam kar raha nahi kar raha. If ulnar nerve was working, adductor pollicis would be good enough here, and you don't have to bend your thumb to hold the book in your hand. That is a test for the ulnar nerve. Next question, guys, which of the following is not forming the boundary for the triangle of safety? Well, the triangle of safety, the triangle which is present on the side here, this triangle is an important triangle for the drainage tube. Drainage tube dalna hai to aapko this it is done in this triangle only, which is called as triangle of safety. And if I just go through these boundaries here, well, the triangle of safety is by this, we have anterior border is by this pectoralis major, the lateral border of the pectoralis major is there. Posteriorly, we have latissimus dorsi. Above we have this axilla, the base of axilla is there, and the base here, the lower border basically is by a horizontal line, a transverse line which is passing through the nipple from the fifth intercostal space. So that is forming the boundary of this of the triangle of the safety here. Mid-clavicular line obviously is not forming the boundary here. Let me just show you the picture for this. Now that's the triangle which is shown over there. That's the triangle of the safety. You can see this margin here, it is by the latissimus dorsi muscle. This anterior margin, it is by the pectoralis major. We have the base of the axilla there, and look at this line, guys. This base below is formed by the horizontal line which is passing through the nipple. That is through the fifth intercostal space here. That is through the fifth intercostal space and that's the triangle of the safety. So mid clavicular line to yahan se jayega na. Mid clavicular line will passing from the middle of the nipple only here. So middle clavicular line is not forming the triangle of the safety. That's a triangle from where the drainage tube is put inside. Right, so that's about the triangle of safety. Chalo, moving on to the next one, guys. The next question is, what is seen in the clump case palsy? Now, this question is simple. This mein kuch bhi nahi hai. That's again an INICET question only. What is seen in the clump case palsy? Well, claw hand is given there. Everyone knows that claw hand will be there in the clump case palsy, but Horner syndrome is also mentioned. Now, had it been the question like choose the multiple answer or something, then you will go with A and D both. But if you have to choose one best answer, then you got to go with the claw hand itself here, guys. Then you got to go with the claw hand here. Now, if this is a brachial plexus, upper trunk is formed by the C5 and C6, and lower trunk is by C8 and T1. Injury to the upper trunk, that is a Erb's palsy. Injury to the lower trunk, that is a clump case palsy. Now, in case of clump case palsy, the thing is that the trunk which is involved is a lower trunk, and the root value affected is a C8 and T1. That's the important point, that root value affected are C8 and T1. And C8 and T1 root value are the major innervation of the intrinsic muscle of hand. Via ulnar nerve and also via median nerve, they supply the intrinsic muscle of hand. And if the intrinsic muscle of hand are gone, then this one common function will be lost, and that will become a claw hand. You will not be able to flex the metacarpophalangeal joint and cannot extend the interphalangeal joint, and the antagonistic muscle will take over. So flexion will become extension, and extended finger will become flexed, and that is the claw hand. You all know that because of the intrinsic muscle, there will be hyperextension at the metacarpophalangeal joint, and there is a flexion at the interphalangeal joint, and that is the claw hand. That is obviously the claw hand in case of clump case palsy. Now, point here is that claw hand is inevitable in case of clump case palsy because C8 and T1 ja raha hai, so obviously the intrinsic muscle of hand will suffer. But Horner syndrome is like may or may not be seen. Now, if the injury is affecting the T1 root value, you know, sympathetic outflow is T1 to L2, guys. T1 to L2 nerve forms a sympathetic outflow. Our first sympathetic nerve is coming from T1 itself here. So, if the injury is affecting the sympathetic part of the T1 also, then you will have a Horner syndrome because T1 nerve, the T1 first sympathetic nerve, will use the sympathetic chain to reach the superior cervical ganglion, and from the superior cervical ganglion, the sympathetic nerve will come out to supply the face. So facial sympathetic supply, although it is coming from superior cervical ganglion, but the preganglionic fiber to T1 se aate hai na. They start from T1 only and they go into the sympathetic chain and then they come out here. So injury to T1 can also lead to the sympathetic loss on face. That is a Horner syndrome. But as I said, Horner syndrome not always seen. So the best answer there is a claw hand here. But if you get a question like in which you can choose both the options, please go with that. Next question, guys, action of the muscle attached to the marked area of the bone here. Now, I'll tell you this again is something which is being asked over and over again. So I would want you to just thoda sa seriously in this topic ko. Muscles around the hip joint, guys. attachment of the greater trochanter, lesser trochanter, what muscles are attached there, and specifically what is the action of those muscles here. Because the question could be anything. Again, they will ask you the question, maybe they will ask you the picture, give you a muscle, and they will ask you the action. Last year they gave you the action and they asked you the muscle on the cadaveric image here. Like, this is also the question asked in which the arrow was placed neither on the greater trochanter or lesser trochanter, it is below the greater trochanter on the posterior surface, and that tuberosity here is called as the gluteal tuberosity. Now guys, gluteal tuberosity gives attachment to the gluteus maximus muscle. Now first thing, we need to know the attachment of these couple of bony projections here, and we also need to know what is the action of the muscle there. Then only these questions will make sense here. So there's a gluteus maximus muscle which will be attached to it here, and the action of gluteus maximus is extension and lateral rotation. Let's see how. Now, once again, the same picture, only the same view. Now guys, this is the greater trochanter. Greater trochanter, on the outer surface of greater trochanter, we have attachment of gluteus medius muscle. Minimus beta aage ki taraf hota. Minimus is on the anterior side. That's a gluteus medius muscle which is on the lateral side. Gluteus medius muscle is a muscle for the abduction of the hip joint. You all read about the gluteus medius muscle in the Trendelenburg test also. So gluteus medius is for the abduction, but it also helps in the internal rotation. Internal rotation gluteus minimus karata hai. Gluteus medius also helps it here. So internal rotation and abduction both are the function of gluteus medius, and this is a muscle. If this muscle is not working, that will be a positive Trendelenburg test also. That is lesser trochanter. Lesser trochanter gives attachment to what? That is giving attachment to the iliopsoas muscle. And here we have the gluteal tuberosity. So this gluteal tuberosity, it gives attachment to the gluteus maximus muscle, as we said, and gluteus maximus muscle is for the extension, and there are horizontal fibers of the gluteus maximus. They also help in the lateral rotation. Most of the muscles in the gluteal region, they help in the lateral rotation except for medius and minimus. अब बाकी सारी muscle देखो, piriformis, obturator externus, obturator internus, gemellus superior, quadratus femoris, all these muscles of gluteal region running horizontally, they all help in the external rotation. So is the gluteus maximus. We have horizontal fiber which will help in the extension and the external rotation again. And then finally we have this lesser trochanter, the muscle which will be coming from the anterior side, the iliacus and psoas, the iliopsoas, the common tendon, and will get inserted here. And iliopsoas is a major flexor of the hip joint here. So if there is an injury or the fracture of the lesser trochanter, hip joint flexion will get hampered. If there is a fracture of the greater trochanter, then abduction and internal rotation will hampered. And if obviously there is an injury to the gluteal tuberosity, then extension and external rotation will be weakened. So yes, for that question, once again, let me show you the question again, that extension and lateral rotation. It's a gluteal tuberosity and gluteus maximus muscle is attached to it here. Okay, moving on guys. Patient with the positive Trendelenburg sign. देखो, अब इस question में what they did is they asked like patient with the positive Trendelenburg sign, what is the action of the muscle involved here? Now we know what muscle is there. That is a gluteus medius muscle. But now they're asking, do you know the gluteus medius muscle? Everyone read about the Trendelenburg test here, so they know it is a test for the gluteus medius muscle. But what is the action of gluteus medius muscle? So we just said it is the abduction and what? It is also the abduction and internal rotation, or you can say medial rotation. So abduction and internal rotation, the question is Trendelenburg test. They're pointing out that the gluteus medius muscle and the function of gluteus medius muscle is abduction and internal rotation. So this is what, either they give you the test or they give you the action, they will ask you the muscle, or they will give you the muscle and will ask you the action here, anywhere around here. Like another last year question again. Yes, wonderful guys, very well. Last year, this was a kind of question they asked, that which of the marked muscle is responsible for the flexion, abduction and lateral rotation of the hip joint? Flexion bhi karaye, abduction bhi karaye, or external rotation bhi karaye. The muscle, which one is responsible for that here? So basically you need to think about the muscle first and then you need to identify that muscle also. Now guys, what muscles are these? What this A, B, C, D muscle are there? That muscle A here is the sartorius. You can see the muscle coming from ASIS and will be going toward the medial side of the tibia, that is sartorius. The muscle B here, that muscle B over there, look at this muscle, that is a vastus medialis muscle, vastus medialis, the B. D is a gracilis muscle, that is on the medial side, that's a gracilis muscle, that's vastus medialis, and that muscle is a rectus femoris. If you remove the rectus femoris muscle, तो आपको अंदर vastus intermedius दिखेगा. Vastus intermedius once you remove it here, and that is vastus lateralis, which is not labeled here. Sartorius, gracilis, vastus medialis, and then see that is the rectus femoris. Well, the answer to this question is obviously sartorius muscle. Sartorius muscle at the hip joint, it is causing flexion, abduction external rotation, and knee joint पे भी it is doing flexion also. So sartorius muscle is having an action at the knee joint also, and there is a flexion at the knee joint. So sartorius is the answer to this question here. So just let me eradicate your confusion because some of you are answering something else here. But a vastus medialis to answer हो ही नहीं सकता. Vastus medialis muscle, vastus lateralis muscle, vastus intermedius muscle, none of them is originating from the hip bone. If a muscle is not originating from hip bone, how can they have action of the hip joint? The only quadricep muscle which is originating from the hip bone is a rectus femoris, this one. A rectus femoris originating from the hip bone, and yes, that is for the flexion at the hip and extension at the knee. A rectus femoris muscle is for the flexion at the hip and extension at the knee here. It's not like a sartorius muscle which is doing the flexion, external rotation and abduction and then the flexion at the knee joint here. Rectus femoris is a part of quadricep muscle. It is contributing to the ligamentum patelli here. So obviously that is causing the extension at the knee and the flexion at the hip joint here. Gracilis muscle is present on the medial side. Adductor compartment muscle. It helps in the adduction. It is one of the muscle helping in the adduction. And vastus intermedius muscle, again it's a quadricep muscle, and this quadricep muscle, as I said, vasti muscle, they do not originate from the hip bone, so their only action is at the knee. Vastus medialis is a muscle for the extension of the knee only. Vastus medialis ho, ya vastus lateralis ho, ya vastus intermedius ho. These vasti muscle are only for the extension at the knee joint here. But yes, you can say vastus medialis muscle, it helps in the locking of the knee here. Locking of the knee mein vastus medialis muscle have a role to play. Yes. So yes, the answer is the sartorius for this question. Chali guys, moving on to the next one. The next question. Which of the following marked structures are affected in the terrible triad or the unhappy triad of the knee joint? Well, I'm sure आपने ऑर्थो में पढ़ा ही होगा unhappy triad and terrible triad here. How about we just quickly go through the identification here, guys. Now look at this. Fibula, tibia is giving you the orientation. That's a lateral side, that's a medial side here. So if I start from here, this A here is a tibial collateral ligament, guys. That's a tibial collateral ligament. Tibial collateral ligament is considered to be one of the remnant of or extension of the adductor magnus tendon. इसको adductor magnus tendon का remnant ही बोलते हैं, extension बोलते हैं. That is tibial collateral ligament. This over there is a menisci, there is a medial menisci. The B is marked as a medial meniscus, and I hope you know that medial meniscus is having attachment to the tibial collateral ligament. That's why tibial collateral ligament की injury में medial meniscus injury भी साथ में हो जाती है. Then look at this cruciate ligament. Obviously, the one which is attached anterior to the tibia, that is anterior cruciate. So this one D is the anterior cruciate ligament, and C that is going posteriorly that to the tibia, going posterior to the tibia, that is a posterior cruciate ligament. So you know that when you look at the cruciate ligament, you need to see the attachment on the tibia. So D is anterior cruciate, and C is the posterior cruciate. E, fibular collateral ligament. Fibular collateral ligament, and that definitely is not attached to the lateral meniscus. This F is a lateral meniscus, क्योंकि बीच में gap भी दिख रहा है आपको, and that gap is giving passage to the tendon of popliteus muscle also to go through it here. Terrible triad, guys. Lateral force की वजह से होता है. When there is a lateral force applied to the knee joint here, then what will happen? There is an avulsion like this. This tibial collateral ligament will rupture. Tibial collateral ligament जाएगा, साथ में middle meniscus को ले जाएगा, and there is also the rupture of the anterior cruciate ligament also. So this unhappy triad is A, B, and D, or guys. A, B, and D. That is an unhappy triad in this here. Look at this. This time the fibula they have shown on this side here. So there is a direction of the force. All these contact sports and all side rugby वगैरह के अंदर बहुत होता है. So if you have the force applied on the lateral side of the, like say, knee joint here, then you can see there is a torn of the tibial collateral ligament. There is a collateral injury to the medial meniscus also, and there is a rupture of the anterior cruciate ligament, and that is a terrible triad or the unhappy triad of the knee joint. Chali, moving on. Well, again, look at this, guys. I mean, the question, I said it could be as simple as this one here. I don't think ये question किसी ने भी गलत किया होगा. Identify the nerve passing through the marked structure here. Now, again, the point is, once they ask this question already here, the next time the question level could increase. Nerve passing from there, what are the branches of those nerves, what exactly the nerve is doing, what muscle it is supplying, injury to that nerve lead to what. So obviously the arrow is on the neck of the fibula, and you know neck of the fibula, obviously what nerve is running from there? That's a common peroneal nerve here. Now have a look at this image just for a little discussion there. Now if you see, guys, that's a sciatic nerve. That's a view from the front here. So that's a sciatic nerve which is dividing into the upper part of the popliteal fossa, obviously on the posterior side. And then we have the continuity, that is a tibial nerve which will continue posteriorly here, that is supplying the calf muscle. So all the plantar flexors are supplied by the tibial nerve. And then we have this common peroneal nerve coming toward the lateral side. As you can see, it's winding around the neck of the fibula. and then dividing into the superficial peroneal nerve and the deep peroneal nerve. Now this deep peroneal nerve is supplying the muscles of anterior compartment. Muscles of anterior compartment, so obviously these are what? Dorsiflexors. And superficial peroneal nerve is supplying the lateral compartment, that means it is supplying the everters. If there is a fracture or the injury at the neck of the fibula, then common peroneal nerve is gone, that means the two nerves are lost here. Deep peroneal nerve supplying the dorsiflexors. If dorsiflexors are gone, that means the foot will come into plantar flexion, and that is a foot drop. If the superficial peroneal nerve is gone, that means both the everters are gone and the foot will come into inverted position. So you not only have a foot drop, you also have an inverted foot also. The equino-varus position of the foot. Equino-varus, guys. The foot is plantar flex, there is foot drop, and there is a varus position also. Equino-varus position of foot because of the common peroneal nerve injury. If the injury is only to the deep peroneal nerve, तो खाली foot drop होगा. But if the injury is to the common peroneal nerve, then we have a eversion loss also is there, and the foot is inverted as well. So foot drop, inverted foot, that is equino-varus position, and we know that the patient with the common peroneal nerve injury, they have a foot drop, and the type of gait they have is a high steppage gait. They need to take the high steps off the ground to clear the foot of the ground, otherwise उनके toes जो है ground में drag करेंगे. So there is a high steppage gait is also seen in that case. पता नहीं आप लोग क्या क्या बातें कर रहे हो इसके अंदर अभी तो I'm not reading the comments. I'll see it later. Let me just quickly finish off these questions. Okay, so just couple of questions more, guys. Structures forming the superior boundary of the foramen indicated in the given image here. So this question, the epiploic foramen, the foramen of Winslow, I always say that in my one shot also, in my regular class also. This is one of the most asked question in the abdomen here, and there is a logical reason for that here. Epiploic foramen or foramen of Winslow is the only connection between the greater sac and lesser sac. And if there is any sort of internal herniation from the greater sac, like cecal herniation to the lesser sac, that obviously is through the epiploic foramen. So that makes this epiploic foramen or foramen of Winslow very important. Pringles maneuver, guys, that's a finger going inside. You all must have heard about the Pringles maneuver also. Now, epiploic foramen relations are something which have been asked over and over again, and the reason is the relations are so important. They are such an important structure surrounding it that it is not possible, or it's not easy for the surgeon to increase the size of epiploic foramen. You cannot compromise the structures which are present around the epiploic foramen. Like, if you look at this picture here, that is the epiploic foramen which is just behind the free margin of lesser omentum. Beta, ye pura lesser omentum hai. That's a lesser omentum. Here we have the attached margin, and that's a free margin. Now, just behind the right free margin of lesser omentum, we got epiploic foramen. So above we have what? We have liver, the caudate lobe of liver, which is the answer to this question. To be more precise, it is a caudate process of caudate lobe of liver. But caudate lobe of liver, that is the answer to this question, that is in the roof. In the floor is the first part of duodenum. I cannot emphasize more on this, guys. First part of duodenum, caudate lobe is above, but first part of duodenum is in the floor here. It is not the pylorus of stomach. I have seen this question that many times they ask the relation, वो जानबूझ के pylorus of stomach देते हैं. Pylorus of stomach is not forming the floor. It's the first part of duodenum which is present in the floor. Don't forget that here. So pylorus, this first part of the duodenum in the floor, and caudate process, caudate lobe of liver is above. If I show you the transverse section, let me just show you a transverse section from this area here, something like that. So that is stomach there. Let's get oriented. That is stomach. This is lesser omentum, and this here is the free margin of the lesser omentum. And look at this blinking structure there. That is the epiploic foramen. This whole thing is a lesser sac, guys. This whole thing is a lesser sac here. So greater sac is connected to the lesser sac by this foramen here. So epiploic foramen or foramen of Winslow is present just behind the free margin of lesser omentum. In the roof, caudate process was there. In the floor, first part of duodenum is there. Abhi anteriorly क्या दिख रहा है आपको? The entire portal triad is there. Because we are inserting the finger just behind the free margin of lesser omentum where we have portal triad. So there is a portal vein, hepatic artery, bile duct, all the portal triad is there in the anterior relation. And the most immediate relation is a portal vein only. Most immediate posterior relation is inferior vena cava. And then we have the right supranal, look at that, right suprarenal gland is there, and the T12 body, the body of 12 thoracic vertebrae is also there here. But important thing is कि आगे भी vein और पीछे भी vein है और कोई ऐसी वैसी vein नहीं, portal vein in front and inferior vena cava behind. And that makes it difficult for the surgeon to increase the size of the epiploic foramen because it is surrounded by the two, probably the most important vein in the body, the portal vein in front and inferior vena cava behind. So if you just look at the immediate relations of the epiploic foramen, all four of them are so important. Caudate lobe is above, caudate process is above, portal vein is in front, first part of the duodenum is below, and inferior vena cava is behind. So it is surrounded by such an important structure that this is always a headache for the surgeons to reduce the hernia from this epiploic foramen or from the lesser sac. Yes, correct, Raj. Okay. Next, guys, we have that which of the following, which of the muscle makes the pelvic diaphragm, guys. Now, again, they gave a question like this in which they've given the multiple options that you need to know everything about the pelvic diaphragm, because if you choose something like, if you know only one part of the pelvic diaphragm, that will not help you. So the four muscles are given over there: deep transverse perineal muscle, the pubococcygeus, the iliococcygeus, and the obturator internus. Now, the muscle out of these, let me just give you the answer first. It's the pubococcygeus and iliococcygeus which forms the pelvic diaphragm. So B and C from this option here. The option could vary in the exam also. But let me give you a quick overview of this pelvic diaphragm. So guys, let's say if this here is a pelvic bone and here is a sacrotuberous ligament here. So let's say it's a lithotomy position आप pelvic bone को देख रहे हो. So that's a pubic bone, that's a ischiopubic ramus. Here is a ischial tuberosity. That is a sacrotuberous ligament, and that is a sacrum there. So let's say you're looking at the perineum from the inferior aspect here. Now there are three muscles which are forming the pelvic diaphragm, and they're all coming from three different parts of the hip bone. So we have a muscle that is called as a pubococcygeus. All these muscles will come to the coccygeal vertebrae. They're all coccygeus muscle. So we have a pubococcygeus, then we have a iliococcygeus, and then we have a muscle called as a ischiococcygeus. So these three muscles are together forming the pelvic diaphragm: the pubococcygeus, the iliococcygeus, and ischiococcygeus. Now collectively these three muscles are called as a pelvic diaphragm. Collectively they are called as pelvic diaphragm. Ischiococcygeus is a kind of vestigial muscle in human. I mean, it is helping to form the pelvic diaphragm, but it is not having any functional importance in us. Ischiococcygeus is a muscle which is more developed in lower animals. Quadrupeds के अंदर इनको tail की जरूरत है. So for the wagging of the tail, for the movement of the tail, the ischiococcygis is required. So in some books they say ischiococcygis, they even call it simply coccygeus also. एक ही बात है. Ischiococcygis or coccygeus, it's the same thing only. Now out of these three muscles, the pubo and iliococcygeus, guys, these two muscles together are also referred as the levator ani. So that's the difference between the pelvic diaphragm and levator ani. When I count these three muscles together, that is pelvic diaphragm. But when I look at these two muscles which are having an action on the anal canal, they can elevate the anal canal, the levator ani. That's the pubo and the iliococcygeus here. And moreover, if you look at the innermost muscle here, the pubococcygeus muscle, now this must be close to all the openings there. Now let's say if this is a section of female perineum and there's an opening for the urethra, vagina and rectum. So it's the pubococcygeus muscle which will form the surrounding these openings like. So we have a muscle around the urethra or the muscle encircling the urethra that is called as a pubourethralis. Look at that. That's an extension of pubococcygeus. Then we have a muscle called as a pubovaginalis, which is covering the vaginal wall. And similarly, we have a muscle which is covering the rectum, that is called as a puborectalis. So all these muscles, pubourethralis, pubovaginalis, puborectalis muscle, they obviously are the modifications of pubococcygeus muscle. Modification of pubococcygeus muscle. And especially this puborectalis muscle is important. It's a muscle of continence. It maintains the anorectal angle. It is also called as a muscle of continence. Behral, the point is that in the pelvic diaphragm, we have all the three muscles of the pelvic diaphragm in here, the pubo, ilio and ischiococcygeus, and the one which were given in the question, the option, the pubo and the iliococcygeus was to choose from. Next question, guys. Injury to the bulbar urethra would result in the extravasation of urine in which of the following sites except. Now, this also is a recent INI question only. The injury is to the bulbar urethra. Now, either you say bulbar urethra or you say the spongy urethra in the bulb of penis. Now, we're not talking about the entire spongy urethra. We're talking about the urethra in the bulb of penis here. And if the injury is there, then where the urine will go and where the urine will not go here. Now, from these options, the answer is deep perineal pouch. But let's see why answer is deep perineal pouch here. But just keep it in mind, it's a bulbar urethra there. Have a look at this picture, guys. Now, extravasation of urine. So, just schematic line diagram for you. Let's say there's a picture of the perineum here. DPP is deep perineal pouch, SPP is superficial perineal pouch. Now let me just give you a very quick orientation there. The first layer there is a pelvic diaphragm, this one is a pelvic diaphragm. Then we have these two layers of urogenital diaphragm, that is superior layer, that is inferior layer, that is urogenital diaphragm. And this space inside the urogenital diaphragm is a deep perineal pouch. The space within the urogenital diaphragm is a deep perineal pouch here, though there are some altered concept nowadays. And then we have superficial perineal pouch which is niche present, that is present below the urogenital diaphragm. The space below urogenital diaphragm is a superficial perineal pouch which is covered with the Colles fascia below. And look at this. This Colles fascia is a continuation of the dartos muscle coming from scrotum, and the dartos is a continuation of the scarpa's fascia from the abdomen. Look at this blue line over there, guys. That's a scarpa's fascia continues as the dartos, and dartos will continue as a Colles fascia behind here that is merging with the perineal membrane. The point to be noted is deep penile pouch band hai, it is closed. Superficial penile pouch is open in front. The urethra which is present in the deep penile pouch, that is membranous urethra. If there is injury to this membranous urethra, if there is an injury to membranous urethra, urine will accumulate in deep penile pouch and will stay in the deep penile pouch until unless iski superior layer or inferior layer rupture ho. So, if I talk about hypothetically that injury to the membranous urethra, the urine accumulates in the deep perineal pouch only. But the injury if to the spongy urethra in the bulb of penis, now that's the question guys, bulbar urethra. Injury to the spongy urethra in the bulb of penis, pehle urine aayega in the superficial perineal pouch. That was a injury to membranous urethra, urine in deep pouch here. But if the injury is to the spongy urethra in the bulb of penis, the urine comes into the superficial perineal pouch. Because there is no anterior wall of superficial perineal pouch, the urine can go into the scrotum, the layer of scrotum. Dartosis continuation of the Scarpa's fascia, the urine can go along the Scarpa's fascia in the anterior abdominal wall also. And Scarpa's fascia goes downward and merges with the fascia lata of thigh. So it can go downward into the thigh also. Not very long, just till the Holden's line, till the pubic tubercle only, but it can go downward into the thigh also. So that's an extra vestige of urine if the injury is to the spongy urethra in the bulb of penis, or in simple word to the bulbar urethra here. So it can go to the superficial pouch, to the scrotum, to the anterior abdominal wall, and also to the upper thigh, the upper part of thigh till the Holden's line. Holden's line is a fusion of Scarpa's fascia and fascia lata. That is Holden's line. Right? So that was the answer to this question, guys, that if the injury is to the bulbar urethra, urine is not going into the deep pouch, baki in sab jagah pe ja raha hai. It can go to the scrotum also, it can go to the superficial pouch also, abdominal wall also. This also was one of the INICET questions that identify the pelvic diaphragm. I told you now, sometimes the questions are so simple, but I always feel that once the question is asked, you have to look into, look, yaar, kuch to alag puchenge mere se. They've asked this question here. I should have placed this question actually earlier, that which one is the pelvic diaphragm here. And then that question was asked, that which of the following muscles are contributing to pelvic diaphragm here. So see, that's the evolution of those questions here. That's what the AIMS, INICET are known for, that they will give you some image-based question or a simple question, and next time usi question ko they keep on asking it over and over again. I always say that INICET compared to the NEET exam, it's the more predictable exam here. We know what they're going to ask here, but their questions are very intelligent, very smartly framed, and that's why sticking to the PYQs and just reading around the PYQs becomes so important in this year. So guys, well, that's first of all, that's a coronal section in which you're looking at the looking at the ischio-anal fossa or ischio-rectal fossa. That's a ischial tuberosity. That is anal canal. That's why this fossa is called as the ischio-anal fossa. Lateral boundary of the ischio-rectal fossa is by this muscle that is called as obturator internus. The muscle which is marked as B is obturator internus. That muscle which is marked as C, that is the external anal sphincter. That's the external anal sphincter. And then we have internal anal sphincter which is above that. And this obviously the obliquely placed muscle here. That obliquely placed muscle is a pelvic diaphragm. Obviously diaphragm mein to aise hi hoga na. This obliquely placed muscle is a pelvic diaphragm which is basically covering this ischio-rectal fossa from above. So in the ischio-rectal fossa we have an apex which is by the junction of this pelvic diaphragm, or you can say levator ani, and the obturator internus. Base mein skin hota on this side. Look at this. The base is just by the skin itself here. And because we are looking at this picture, so I should tell you one thing, that the ischio-rectal fossa ka main content is a fat. We do have a pudendal canal. Guys, can you see that on the side here? I hope you can see that. There is a pudendal canal which is present on the side here. And the structures which are present in the pudendal canal, they are quite safe. वो side में run कर रहे हैं, कोई problem नहीं है. So all these pudendal nerves, internal pudendal vessels, they are going from the side only. So problem नहीं है. Except for the inferior rectal nerve and inferior rectal vessels. Inferior rectal nerves and vessels, they have to traverse like this. They have to travel like this transversely to reach the sphincter and the anal canal. And that's why the inferior rectal nerves and vessels are likely to get injured when you drain the abscess from the ischio-rectal fossa. Agar yahan par koi abscess hua and you want to drain that abscess here, then the chances of injury to the inferior rectal, remember that inferior rectal nerves and vessels are the one which are vulnerable to injury here. But for this question, for this particular question, yes, the answer is simply A, that is the pelvic diaphragm or levator ani. Which brings us to our last two questions here. Now, which of the following is not the branch from the posterior division of internal iliac artery? You will find this question asked like multiple times. Not only in INICET, previously AIMS also, like I've seen this question asked in the PGA exam as well, in the NEET, AIPG ke time mein poochte this question ko yahan pe. And the question remains the same only. What branches are coming from anterior division of internal iliac? What branches are coming from posterior division here? Now, if you remember these branches, good for you. If you don't remember these branches, at least do one thing. Remember the branches coming from posterior division, because there are only 3 branches. So you can always solve this question by the method of elimination. Like guys, internal iliac artery divides into the anterior and posterior division, and posterior division is just having these 3 branches. Now first of all, let's try to apply some logic here. The posterior division, guys, posterior division is close to the posterior, that is toward the sacrum, gluteal region, lumbar region, पीछे wall की तरफ है. So the branches coming from posterior division, they all these branches are the, like you look at those branches, they are supplying the wall only. In fact को नाम से पता चलता है, देखो, iliolumbar artery, lumbar, lateral sacral artery, sacrum, superior gluteal artery, gluteal. So all these branches, they are not vascular, they are not what do you say, these branches are not supplying the viscera, they are supplying the wall. They are the posterior division here, पीछे की तरफ है, sacrum, lumbar region. So they are supplying iliolumbar, lateral sacral, superior gluteal, all these arteries there. Anterior division is supplying the viscera. Majority of the branches from anterior division, वो सब visceral branches है. Look at superior gluteal, inferior gluteal, vaginal artery, obturator artery, then we have uterine artery, all these artery, middle rectal artery, internal pudendal artery. So they are supplying the viscera. So the 3 branches from posterior division, I'm sorry, the 3 branches from posterior division, that is iliolumbar, lateral sacral, and superior gluteal artery, and you can go with these, and you can always do this question by the method of elimination also. If you don't remember the branches of internal iliac, and at this point of time I can say this to you, that go with the method of elimination here. So internal pudendal artery is the answer in there. These 3 are the SIL, 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 the 3 branches are from the posterior division. Then we have this question here, that following appendectomy, bleeding is seen, which of the following artery should be ligated? Now appendectomy hai, to obviously appendicular artery is bleeding. If appendicular artery is bleeding, we just need to know that which appendicular artery is coming from where, guys. So let me just put this picture here. Now the answer for this is the iliocolic artery. Now look at this, guys, that's a superior mesenteric artery there. Now we know inferior mesenteric artery is to supply the hindgut. So the branches of the inferior mesenteric arteries, like left colic artery, we have a sigmoidal artery, and we have a superior rectal artery. These arteries going toward the left side, descending colon, sigmoid colon, and rectum को supply कर रही है. Superior mesenteric artery, if you look at the superior mesenteric artery, can you see all these cut branches over there? Now these small branches which are cut over there, they are going to supply the jejunum and ileum. So these branches are jejunal and ileal branches. And the major branches of superior mesenteric artery are given toward the right side. Like look at that. The first we have a middle colic artery. This one is a middle colic artery which is going to supply the transverse colon, the major part of transverse colon. After that, look at this artery here. That is a right colic artery that is supplying the ascending colon. And look at this one, guys. This is the iliocolic artery. And if you look carefully, iliocolic artery is giving a branch to the cecum. And then this branch which is going behind the terminal ileum to supply the appendix also. So appendectomy agar bleeding ho raha hai, to obviously you have to ligate what artery? You have to ligate the artery from where the appendicular artery is coming from, and that is iliocolic artery. That is the iliocolic artery. So that is a middle colic here, that is a right colic, and this one is the iliocolic artery supplying the cecum and appendix, supplying the cecum and appendix. So that is about it. Now, yes, guys, I have not discussed anything in histo here. Histo bhi question aate hain, aisi baat nahi hai. I've one hour video I've already discussed, like during the NEET exam, that general, just I would recommend you to just go through that video only, because whatever images I've discussed in that, they were all from the INICET part itself here. So don't do anything special for the histo, I would say. Histo pe general histo is something that they can ask you here, and general histo I've already discussed on the YouTube only. That video is lying in the same the group only. You can just again go through that part only. And one question from the histology will be there. I can tell you that the question will be from the general histology. So just don't go into the just don't waste your time in the system histology. That's not the time. It's not the time to invest your time into something which is like rarely asked here. There will be question from the histo part here. General histology will be there, and that we have already discussed. उसके लिए हमने already एक video record किया हुआ है. So it's already there here. So that's all from my side, guys. Thank you so much for listening to me, and especially maintaining this attendance of almost 350 people, and I've taken almost more than 2 hours. Wow. Okay. And yes, it is not over until we win. So just go like a lion, roar like a lion in this exam here. Go with the confidence, guys. Whatever you read is enough. It's just that you need to that day your brain should work to its maximum potential. Zyada forma mein nahi aana. What people are reading, what they're doing, just don't worry about that. Stick to your sources, whatever you read it from, wherever you read it from. whichever platform you read it from, just stick to that only, and just keep revising the previous stuff, keep going through the previous year questions, and be smart in this paper. INICET is an exam which tests your not only your knowledge, it also tests you that how smart you are, how street smart you are when you're answering the questions here. So you'll find certain questions for which you don't know the answer at all, absolutely not here. But when you look at the options, you can eliminate the options here, and that game will really, really work for you if you can do that here. Right? So thank you so much, and thank you so much for so much of love that you gave me for my previous one-shot video. Also, you write that it crossed 4 lakh views. Like, I've never expected to go to that level. And yes, I'm going to share this this PDF right away. Like the moment this video is closed, and within 5 minutes that PDF will be there in the group here. So thank you so much, and all the best.